making a director of public health, sir. So are you using
Sir. પછી ધ્વનિબેનને આપી દેજો. બસ बढ़िया आप कैसे हो? खड़को आगे बड़ा
to the respected dignitaries, esteemed members, delegates, and guests. What have we a better start to the winter? It's an honor to welcome you to the Oratory feast, the event we all have been waiting for, and the conference of the Indian Association of Preventive Medicine, IASM Gujarat chapter. We, on behalf of Indian Institute of Public Health, Gandhinagar, extend a heartfelt welcome to each one of you. And thank you for joining us where we all engage in the 2 days academic extravaganza. Myself, Dr. Megha Baba, faculty at IIBHG,
And I am Dr. Smita, the consultant and medical supervisor here at IIBHG, will be along with you for the next 2 days. This annual gathering is not just a platform for presenting research, but a space where we celebrate our shared passion for improving the health and well-being of our communities. It is a moment for us to reflect on the progress we've made and the challenges we face, and most importantly, the collaborative efforts that will help us shape the future of community health. Without wasting a moment, today we begin with a special occasion, with it as auspicious and spiritual note by evoking the presence of Lord Ganesha, the remover of obstacles, the god of wisdom and prosperity. Lord Ganesha, with his divine grace, is revered as a patron for new beginnings, ensuring that all our endeavors are successful and free from hindrances.
In honor of Lord Ganesha, we present to you Mangal Charan, a Ganesh Vandana in Odissi dance form. This performance is not just a dance, but a heartfelt invocation, where the rhythm of music and grace of dancers come together to express our reverence and gratitude to Ganesha. As the dancers take the stage, let us open our hearts to the blessings of Lord Ganesha. And may this performance set the tone for a day filled with positivity, joy, and harmony. Please welcome the performance as they present the Ganesh Vandana. Today, we have Preetha Ball and Purvita Banerjee, who shall be presenting the beautiful rendition to Lord Ganesha. Please welcome them.
breathtaking. Thank you so much for that spectacular performance.
We are fortunate to be part of a dynamic and growing network of professionals who are not only experts in their fields, but are also deeply dedicated to creating sustainable and impactful solutions for public health challenges. The sessions planned for today and tomorrow promise to be enriching, offering invaluable insights into the latest research, innovations, and practical strategies that can be implemented on the ground. Our esteemed keynote speakers and panelists bring a wealth of knowledge, and their contributions will undoubtedly stimulate discussions and ideas that will inspire new directions for all of us.
We encourage everyone here to participate actively, to engage in thoughtful discussions and network with fellow professionals. These interactions would not only deepen our understanding, but also strengthen our collective mission for improving public health across Gujarat and the country. Our theme for this conference is Building Synergy for a Resilient Healthcare System. The healthcare landscape is undergoing a period of unprecedented transformation. The current healthcare system is marked by a multitude of factors, including accessibility, emerging infectious diseases, the growing burden of chronic illnesses, and the ever-present threat of natural disasters. Rapid environmental changes and health emergencies also pose significant challenges to the efficacy and effectiveness of the healthcare systems worldwide. Such a dynamic environment necessitates a healthcare system that is resilient and capable of withstanding unforeseen disruptions.
To build synergy for a resilient healthcare system, collaboration among various stakeholders, including healthcare professionals, public health experts, social scientists, policymakers, synergy for a resilient healthcare system emphasizes the importance of collaboration and synergy across the entire healthcare ecosystem. It highlights the critical need for coordinated efforts to strengthen healthcare delivery in the face of ever-evolving challenges. The conference's aims to foster a dynamic.
It's time to welcome our dignitaries on the dais. Give a warm round of applause to welcome Dr. Deepak Saxena, Organizing Chairperson and Director, IIPHG. He is a distinguished public health educator and researcher. Previously, a professor at IIPHG and faculty at Government Medical College, Surat, he is celebrated for his achievements, including the Australian Leadership Fellowship and the T5 Fellowship from Boston University. With one national and one international patent, he champions innovation in public health. At IIPHG, he leads the Nidhi Techno-Business Incubation Center, DST supported, and COED, which is University of Bonn supported, fostering entrepreneurship and interdisciplinary health solutions. Through his leadership, IIPHG thrives as a hub for academic excellence, research, and impactful public health advancement globally. I request Dr. Mahavir Golecha, sir, to please welcome.
I would now like to invite Chief Guest of the conference, Professor Sanjay Zotpe, Patron and President, PHFI. Sir is the President of the Public Health Foundation of India, a leading figure in public health. As the founding director of Indian Institute of Public Health, Delhi, and former Vice President for Academics at PHFI, he has shaped public health education in India. With honorary professorships at renowned institutions and a DSc from DMIMS University, he is recognized for his contributions to medical science and public health.
Professor Zotpe's leadership spans research, advisory roles, and policy making, advancing global public health initiatives. We welcome you, sir. I request Dr. Shalu Chaudhary to welcome sir.
I would now like to invite on stage Dr. Vikas Desai, Public Health Expert and Technical Director, UHCR CE Surat. Dr. Vikas Desai, a public health expert with over 5 decades of experience, specializes in urban health, climate and community nutrition. She holds an MD in community medicine and an MSc in applied nutrition, with fellowships from UNICEF and the UK institutions. As Honorary Technical Director of the Urban Health and Climate Resilience Center of Excellence, she has published over 115 papers, organized 33 conferences, and contributed to global health policies. Dr. Desai is also an advocate for societal change, leading women's cooperatives and influencing urban resilience strategies. Ma'am has played a key role in shaping the foundational journey of IIPHG as an EC member. A very warm welcome to you, ma'am. I request Dr. Somin Shah to please welcome ma'am.
Ladies and gentlemen, let's welcome our guest of honor, Dr. Anna Rao Kulkarni, IAPSM National President. Sir is the professor and head of community medicine at Sri Madhusudan Sai Institute. With over 45 years in healthcare, he has played a key role in developing primary healthcare systems in Saudi Arabia and Dharavi, India. Dr. Kulkarni contributed to the WHO polio eradication program and currently serves on the Health Ministry's Technical Advisory Group. As chair of the NMC CBME Review 2024, he drives curriculum innovation and leads the Nutrition for Lifelong Health project, reflecting his commitment to advancing public health. We welcome you, sir. I request Dr. Komal Shah to welcome sir. With great pleasure, I invite Dr. Purushottam Giri, IAPSM Secretary General, on dais. Sir is professor and head at IMSR Medical College, Badnapur, has 17 years of undergraduate and 12 years of postgraduate teaching experience. As Secretary General of the National IAPSM 2022 to 2025, he has contributed to advancing public health education and policy. A prolific researcher with over 200 scientific papers and multiple books, Dr. Giri focuses on epidemiology and public health management. He is a sought-after keynote speaker on topics like competency-based medical education and public-private health partnerships, playing a key role in advancing community medicine and public health. I request Dr. Harsh Shah to welcome sir.
Let us now welcome Dr. Bhavesh Modi, IAPSM Gujarat State President on the dais. Dr. Bhavesh Modi, Professor and Head at AIIMS Rajkot, is a distinguished public health expert with over 20 years of experience in teaching, research, and health program management. Renowned for his work on tuberculosis control and maternal and child health, he has received 12 prestigious awards, including the WHO Zero Citation. With over 75 publications, over 100 presentations, and 10 book chapters, Dr. Modi bridges the research and policy to advanced evidence-based health strategies. His leadership at AIIMS Rajkot drives innovation and strengthens health system, impacting public health nationally and globally. I welcome you, sir. I request Dr. Jalavi Panchamya to please welcome, sir.
Give a loud round of applause. Please join your hands for Dr. Atul Trivedi, IAPSM Gujarat State Secretary. Sir is Associate Professor at BJ Medical College, Ahmedabad, and Secretary of IAPSM Gujarat Chapter. Has 27 years of expertise in teaching, research, and public health practice. He has mentored students, developed curricula, and led impactful initiatives like the Micronutrient Support Unit with UNICEF and Gujarat's government. Active in disaster management, epidemic investigations, and health surveys, he has contributed to major studies, including the National Non-Communicable Disease Monitoring Survey. Dr. Trivedi's extensive publications focus on communicable diseases and lifestyle disorders, advancing public health education and research. We welcome you, sir. I request Dr. Apurv Kumar Pandya to welcome, sir.
Please welcome Dr. Anish Sinha, Organizing Secretary and Registrar, IIPHG. Dr. Sinha has an experienced public health expert specializing in immunization and health system strengthening. From 2004 to 2016, he served as a surveillance medical officer with the WHO, contributing to polio eradication and immunization efforts across India. In 2016, he joined the UNDP and led the successful implementation of the Electronic Vaccine Intelligence Network, the EVIN, in Gujarat and Indonesia. Dr. Sinha's experience spans child health, immunization, health system strengthening, and environmental health with a focus on sustainable and equitable healthcare solutions. Welcome, sir. I request Dr. Anurag Saxena to please welcome.
We welcome all the dignitaries on the dais with a loud round of applause. As we embark on this intellectual journey, it is customary in our tradition to begin such occasions with the lighting of the lamp. Lighting the lamp is a symbolic gesture of bringing light into our lives, dispelling the darkness of ignorance and igniting the flame of knowledge, wisdom, and enlightenment. I invite the dignitaries on dais to kindly light the ceremonial lamp, which will mark the formal inauguration of this conference.
गया हो गया हो गया.
Thank you. Now let's move forward in the spirit of wisdom, positivity, and success. I would now like to invite and request Dr. Deepak Saxena, Organizing Chairperson and Director IIPHG, to address this gathering.
Respected Chief Guest Professor Sanjay Zodpe sir, President Public Health Foundation of India, Guest of Honor Dr. Anna Rao Kulkarni sir, President of Indian Association of Preventive and Social Medicine, respected Vikas ma'am, a lifelong mentor for many of us who are sitting here in Gujarat, and also to IIPH Gandhinagar, Dr. Giri, Secretary IIPSM, Dr. Bhavesh Modi, President IIPSM Gujarat Chapter, Dr. Atul Trivedi, Secretary IIPSM Gujarat Chapter, distinguished stalwarts of PSM subject, my fellow colleagues from Community Medicine Fraternity, Public Health, and my dear students. On behalf of IIPH family, it's with great pleasure and pride I extend a very warm welcome to all of you at IIPHG campus for this 31st Annual State Conference of Indian Association of Preventive and Social Medicine Gujarat Chapter and 13th Annual Conference of Indian Public Health Gujarat Branch, along with 7th Annual Conclave of Students of Public Health ACES 2024. At the onset, I should thank IIPSM Gujarat Chapter for giving us this opportunity to organize this conference, that too exactly after 12 years. From a small team, rented campus, and with only one academic program in 2012, IIPH Gandhinagar has now matured into a renowned UGC recognized public health university of repute and has excelled both in academics as well as research. IIPHG now offers Masters in Public Health. We have Masters in Hospital Administration, track in Public Health Nutrition, PhD programs, fellowships, and we are actively engaged in research with multiple Center of Excellence. To name a few, ICMR recognized Collaborating Center of Excellence for Biomedical Research, DHR supported Health Technology Assessment Hub, DST supported Techno Business Incubation Center, Center for One Health, Center for Non-Communicable Disease, and also we are recognized as Campbell Center for Systematic Review and Meta-Analysis, QualIPS, and many others. These all are testaments of our efforts in fostering public health education as well research. We are now hub for multiple short-term training, well recognized within India as well as globally. I'm happy to share that IIPH Gandhinagar is actively engaged with Ministry of External Affairs, Government of India for the prestigious iTech program, which is open for citizens of 200 countries across globe. We are recognized by Coal India for Management Training Program. We are recognized by Government of Madhya Pradesh for Nursing Faculty Leadership Program. We are recognized by Government of Uttar Pradesh for Medical Officer Induction Program. And of course, we are recognized by Government of Gujarat through SHSRC for Health Leadership Enhancement Program. One thing which is very explicit in present day with rapidly evolving scenario of public health and emerging public health challenges, an urgent need for knowledge sharing, deliberations, collective actions with adequate networking and collaborations. And this is in sync with the theme of this year's conference, that is building synergy for a resilient healthcare system. The plenaries over next 2 days are thoughtfully crafted with best of the speakers from academia, from industry, from experts, from public health practice, from within state, as well as from other parts of country. I'm confident that the knowledge, perspective, and ideas exchanged during this conference will ignite innovative approaches, foster impactful solutions. So let's all seize this opportunity to learn from each other, expand our academic horizons, engage into meaningful discussions, develop networks, and look forward for better outcomes from this gathering. I'll end up with a quote from Henry Ford that I have witnessed, I have learned, imbibed from my alma mater, Department of Community Medicine, Government Medical College, Surat. It's something like this: coming together is beginning, keeping together is progress, working together is success. So let's work together for our collective success. Thank you very much, and Jai Hind.
Thank you so much, sir. I would now request our chief guest, Professor Sanjay Zotpe, patron and president, PHFI, to enlighten the audience with his words of wisdom.
Thank you, Megha, and good morning. Distinguished guests, we have Professor Vikas Ben Desai, leadership of our associations, Indian Association of Preventive and Social Medicine and Indian Public Health Association, Professor Annarao Kulkarni, Professor Giri, Professor Atul Trivedi, Professor Bhavesh Modi, and institutional leadership, Professor Deepak Saxena, who is the director of IIPH Gandhinagar, and Professor Anis Sinha. We have luminaries from the field of community medicine, my colleagues for several years in the field of community medicine, Professor Pradeep Kumar, Professor Bakshi, Professor Kosambia, and students, participants, distinguished faculty. It is absolute pleasure to be here today morning as a part of the 2 days conference that is being organized by IIPH Gandhinagar, which is one of the PHFI institute that we have set up in India. Public Health Foundation of India has set up 5 Indian institutes of public health. And Gandhinagar was one of the institutions that was set up in 2008. The operations started in rented premises in Spicer campus with 1 postgraduate diploma program, has now full-blown university as one of the public health university of the country. And therefore, I would like to congratulate for the growth of the institution and the current leadership of the institution for taking initiative to organize this conference, because I firmly believe that the discourse, disquisition, discussions, and deliberations in the conference would help us to advance the public health agenda in the country. We have several challenges as a country in the context of public health. Although we have done quite far, we'll have long a journey since independence. Our infant mortality rate has dropped down to now 27 or 28 per 1,000 live births. But it doesn't compare well with a single-digit IMR in some neighboring countries like Thailand and Sri Lanka. Our life expectancy is still second lowest life expectancy in the South Asia. We have several challenges, although we are committed to take care of tuberculosis, but we still have most number of cases of tuberculosis being hosted here. Unfortunately, we are labeled as the diabetes capital of the world. Air pollution takes an account of around 1.6 million premature deaths, which are attributed to the air pollution in this country. More than 1 million deaths are attributed to the tobacco. Inequities are rampant. A girl child born in Chhattisgarh or Madhya Pradesh is 10 times more likely to die as compared to a girl child born in Kerala. So much of rampant inequities are visible. If we really wanted to address our public health challenges, we'll have to remind ourselves that our national bird is peacock and not the ostrich. We'll have to look around to fix these problems. And I believe that the conference like this provides this opportunity to deliberate and discuss some of the critical issues to resolve these public health challenges. And the research that probably which would be discussed, and there are so many paper presentations, I looked at the scientific program, which is very well crafted. actually would provide an opportunity to discuss on some of the critical issues in the context of the research that is being carried out, but also identifying what are the priority areas to undertake research in the state and in the country. Because we all recognize it should be socially relevant. We all need to remind ourselves that the science is sterile if it lacks the social relevance, and our policies would crumble on clay feet if they are not firmly placed on merely a tool. What ultimately benefits to the society is the knowledge. And therefore, from the context of knowledge, we generally talk about knowledge generation, because research is a tool to generate the knowledge. We really need to see that how we translate that knowledge into our programs and policies. And therefore, some of the sessions that are crafted out actually are linking research to the programs and policies is very useful for the deliberations. I'm happy that we have a substantial number of postgraduate students and faculty across the state, and some of them coming outside the state also participating in this conference. I wish the conference very productive deliberations and organizers a successful endeavor. Thank you so much.
Thank you so much, sir, for your words of wisdom. I would now request our guest of honor, Dr. Annarao Kulkarni, IAPSM National President, to present his intellectual thoughts with this gathering.
नाहं कर्ता हरिः कर्ता तत्पूजा कर्म चाखिलं तथापि मत्कृता पूजा तत्प्रसादेन नान्यथा आपादमौलिपर्यन्तं गुरूणाम् आकृतिं स्मरेत् तेन विघ्नाः प्रणश्यन्ति सिद्ध्यन्ति च मनोरथाः. Dear friends, it gives me immense pleasure to be standing in front of you for this inaugural function of this joint conference, 31st Annual State Conference of Indian Association of Preventive and Social Medicine, 13th Annual Conference of Indian Public Health Association, Gujarat Chapter, and 7th Annual Public Health Conclave, organized by the IIPHG. So the theme of the conference, Building Synergy for Resilient Health System, is very thoughtfully chosen. Building synergy among health system strengthening, primary health care, universal health coverage, and global health security is important in the face of shortage of healthcare services and health crisis all over the world, particularly in underserved populations. The current healthcare system is marred by the multitude of factors, including a vast population, uneven distribution of resources that Dr. Zodpe sir has just mentioned, rising healthcare costs, increasing demand for accessibility, the growing burden of chronic non-communicable diseases, re-emergence of some infectious diseases, and the ever-present threat of natural disasters. Rapid environmental changes and health emergencies also pose significant challenges to the efficient and effective healthcare systems. Now, some of the ways to build resilient healthcare system, I thought, was we have to invest in the essential public health infrastructure, very, very essential. Build a strong foundation for a primary health care. We have been giving only lip service to primary health care all throughout, from our independence days. Unless we have a very strong foundation in public health, we will not be able to solve most of our problems. Create an enabling environment for research, innovation, and learning. Address health inequities and its impact on the marginalized and vulnerable populations. Promote healthy lifestyles to reduce the burden of health system. Now, as IAPSM President, I would just like to inform you all that we have started from the Indian Association of Preventive and Social Medicine. From the time I have taken over as president from 1st April, we have done some important things for the benefit of association members. I would like to bring to your notice. The first and foremost is, I took over on 1st of April 2024, and 2nd April, the next day, Okay, we conducted IAPSM WHO quiz. Just like every year, the preliminary round was conducted on 2nd April, and the final round was conducted on 8th of April. I think all of you also, or most of you, have participated in this round. The beauty of this quiz was, okay, 26,773 students, MBBS students, from 393 medical colleges from all states and union territories in India participated, and it created 3 world records. Okay, these records were recorded in the World Records of India, OMG Book of Records, and International Book of Records. On World No Tobacco Day, which was celebrated on 31st May 2024, okay, we conducted a create-a-thon competition and idea fusion competition for postgraduate students and faculty. This was very well accepted. And Academia IAPSM, okay, through eConnect, conducts regularly, for the benefit of postgraduate students and the faculty, career track series, PG seminars, journal club, public health update series, and so many other activities. I think some of you are taking benefit of these activities. We have started IAPSM blogs, and we also have infographics. Now, I have started a new project which I feel is very, very important for all of us. In collaboration with IIT Bombay, I have started what is called as Nutrition for Lifelong Health. Now, this nutrition from birth to death, if we take care of our proper nutrition, we understand the nutrition properly. What I really feel is we have to unlearn a lot of things which we have already learned, because nutrition is not understood, and whatever is written. In fact, I had a discussion with director of NIN Hyderabad when we had a conference in NIN itself, and the evidence that they are producing is changed every few decades, or maybe 15, 20 years also. Like when I was a medical student, 1979, first guideline was given, and there, say for example, adult male sedentary worker was recommended to take 460 grams of cereals. Then in second revision, it was reduced to 375, from 460 to 375. In the third guideline, it was reduced to 275, and now still they are thinking of reducing. And I want to bring to your notice here is, in Bhagavad Gita also same recommendation is given, which was written 5,000 years back. Okay, Aharas tvapi sarvasya trividho bhavati priyaha yadnyas tapas tatha danam tesham bhedam imam shrunu. Okay, 3 types of foods are there, which NIN also recommends 3 types of foods only. Okay, sedentary workers, moderate workers, and heavy workers. Similar guidelines, which is valid even today. So what I want to stress here, we have to go back to our scriptures, understand what is good, and retain that. Take very good what is available in the modern research, and we have a combination of the both to make us healthy. This is one project that I have started, and I'm a standing example of the benefit that we have seen in this project. I was a known hypertensive, being treated by the best doctor with the best medicines. For the first 3 years, he gave me 1 tablet, and after 3 years, he said, "Sir, it is still not getting controlled. I want to add 1 more tablet." I said, "Okay." He added 1 more tablet, and after another 3 years, he said, "Still it is not getting controlled. Okay, I want to add another tablet." I said, "What is this?" "Okay, you are the best doctor, best medicine you said, and I am following all the instructions that you have given. Okay, and still it is not controlled. I don't want your medicine." Okay, by that time, I came in contact with this IIT Bombay team, and they were working on this nutrition for lifelong health, and I am simply following a lifestyle modification, and I am free of drugs for the last 6 months, and my BP is never crossed 120/80. What I want to tell here is, so we have a very, very important medicine in our hand in preventive and social medicine, lifestyle modification, so which we have to practice. This is one project that we have started. The second project is family adoption program. I think most of you know, we conducted all India competition for undergraduates and postgraduates for family adoption program in the form of essays, and it was very well appreciated, accepted by the students. We had more than 8,000 essays, and there are hundreds of reviewers who reviewed these things. So this is one important thing, and I want all of you to understand that family adoption is very, very important for us from 2 points. One is educating, quality education of community medicine for the students and providing quality healthcare services to the community. Both these things can be done if we adopt this properly. Then we have done some memorandum of understanding after I took over as a president with Swami Vivekananda Youth Movement for tribal health exposure. 2 batches have been already posted, and they are very good reviews from those students. And then we have a MOU with the QDwell software for following up in the Nutrition for Lifelong Health program. We have MOU with Search. All of you must be knowing Abhay Bang. Recently he was there in our institution, and he said we are starting 2 fellowships in collaboration with this Search organization, and 2 people from IAPSM will be sponsored by Search for 2 years, and they will be paying 1,25,000 as a stipend for that. And this is a very good experience, I feel. If any one of you are interested, you can contact our secretary through the email, and we will process that further. Then we also have a MOU with Kasturba Health Society. Recently, myself and Giri went, and we are planning to have our permanent headquarters of IAPSM in Wardha, that is Sevagram. So these are some of the things which I have started as a president. Now I will come back last few sentences about the institution from where I come. I am a professor and head of a community medicine department in Sri Madhusudan Sai Institute of Medical Sciences and Research, which is the only institution in the whole world where there is no billing counter. The MBBS admissions are absolutely free. The students comes with only 1 pair of dress. The dress in the form of university, in the form of uniform is given by the institution, books are given by the institution, laptop is given by the institution, free hostel, free food, free education, all this with quality education. We never compromise on the quality. The example of this is seen in the result that we have seen. Because just last year we started, the first year result, we have only 50 admissions. NMC gave me permission for 100, but we took only 50 to maintain the quality. And out of the 50, 35 passed with distinction and remaining passed with first class. No question of second class. This is about education. We have Veda, Vidya, Vaidya, all 3 in the same campus. Everything is provided free of cost. Medical students are taught 4 Vedas, and the shlokas are recited. Just like we had invocation here, the Veda shlokas are recited by the medical students, in all functions. So this is just what I want to emphasize is the importance of our ancient culture, traditions, and our literature that is available. We have to go back and integrate that and make full use of that. I thank the organizers, for organizing such a wonderful conference. We have been enjoying. And to end, I will just recite one shloka from Bhagavad Gita. That shloka says, Nahi jnanena sadrisham pavitra miha vidyate tat swayam yoga samsiddha karyanato vandate. So this yajna, Jnana Yajna, is being organized here for 3 days, and you are all very lucky to participate in Jnana Yajna and take full advantage of this Jnana Yajna, and I wish a grand success for this conference. Thank you.
Thank you, sir, for an insightful and inspiring address. I would now like to request Dr. Vikas Desai, ma'am, Public Health Expert and Technical Director, UHC RC Surat, to kindly address the gathering.
All dignitaries on the dais and all future of IAPSM. In fact, I was just talking about that when I joined the department in 71, the subject, I was the only lady in preventive social medicine. I passed in preventive social medicine, not community medicine. And now the sex ratio is altered. And that is a change. So public health and primary health care has passed through several cycles and turmoils, and things are changing day by day. I was just asking if I have faced this. I'm not here to give you guidance like the others have given. I'm just sharing my experience. I was traveling by train and then lady, so somebody asked me, "Are you teacher?" I said, "No." "Doctor?" I said, "Yes." Then doctor is gynecologist or surgeon? I said, "No." "So preventive social medicine, what is it?" And I could not reply, "What is it?" You just explain prevention of diseases, understanding of diseases, what is that? So that's where we stand. I also would like to share with you that I always believe that we deal with the end product of the problem. Origin is somewhere else, in some other department. And here, Deepak, people mentioned various departments and faculties. What is missing is planning. What is missing is environment, climate. Even all these departments are linked with us. And if you see the Nirogi Bal Varsh 2018 approach, it had all enlisted departments. That means everyone is responsible and everyone has to contribute, including community, for preventive medicine. And that's where the challenge lies. Communication is another gap which we are facing. People don't talk about the issues with clarity, understanding the community with whom you have to work with. And that's where the challenge lies. Otherwise, everyone is expert in community health, public health. Everyone is expert. And you must have realized that during Corona, everyone can guide, except people from community medicine. Everyone can do everything. So we have to accept that and raise our voice and our expertise to that level. And I believe unless basics are strong, no amount of AI, meta-analysis will help us in making our status. And it's important that we strengthen our status. मैं तो इतना ही बोलूँगी कि बहुत मुश्किल से हम लोग ये चैप्टर IAPSM का गुजरात का शुरू हुआ था सूरत से, क्योंकि there was no identity with us. And then it was a branch of IAPSM Gujarat state at Karamsad. बहुत मुश्किल से यहाँ तक पहुँचे हैं. आप लोग को आगे बढ़ाना है. All the best.
Thank you, ma'am. It's an inspiring address for our budding public health professionals. Before we move forward, I request Dr. Bhavesh Modi, IAPSM Gujarat State President, to recognize the efforts of Public Health Retreat 2024, an educational visit organized by IAPSM GC. Dr. Harsha Solanki. I invite Dr. Harsha Solanki on stage. A loud round of applause. Dr. Mohit N. Makwana. Dr. Margi Sheth. Dr. Mohit Makwana. Let's fill the air with our sound of the cheers, sounds of claps. Thank you so much, sir. I now request Dr. Bhavesh Modi sir to please share his thoughts.
Very good morning, dignitaries on the dais, and I am seeing many more dignitaries off the dais. So this is a formal designation given to us to run the show, which is started by stalwarts like Vikas Madam and Niyogi sir, and before so many years. As Kulkarni sir has given his report card, I would briefly tell what activities we have done in last 8 months. So first, as said by Kulkarni sir, as part of national level quiz, we also did in all the, not only in all the medical colleges, but we also did state level quiz at BJ Medical College with Dr. Atul Trivedi and entire team of BJ Medical College. Thank you so much for that. This is photograph of the same, Pradeep sir and entire team. Another activity which was successfully, this is the winners and participants of the quiz. You can see from all over Gujarat, the first 4 teams were called and quiz was conducted. Another activity, when I was doing my MD, I was forced to do 2 weeks gender sensitization workshop, and that was immediately after my marriage. So similar activity we have also started in 2 places we did along with the Sehat. One at BJ Medical College, another is Pramukh Swami Medical College. Pramukh Swami was coordinated by Dr. Manisha Ben, and BJ Medical was again coordinated by team of Ahmedabad. So thank you for that. These are some photographs from the same. These are BJ Medical photographs. Earlier were from Karam sir. You can see what they are trying to sell. I am not sure, but it's a difficult subject. In addition to this, also as part of our training and research related qualitative workshops were also conducted. Last one was conducted at Gotri Medical College with Dr. Sunil Nayak and entire team. So these are photographs of Team Baroda, Government Medical College Baroda faculties as well as Gotri with support of the chapter, Dr. Para, Kedar, all of them. You know they are also teaching at national level. The last activity for which we felicitated our 3 young faculties was public health retreat. Some of you are sitting on this side know we started this activity just before COVID with 53 students, and that was first IAPSM Young Conclave which was at Varda, and under leadership of Zodpe sir and Kadri sir we went there, and replica of that was done this time with this entire team led by Dr. Harsha, Dr. Mohit and Dr. Margi, facilitated with guidance of Atul sir and Manisha Ben, and even they also went with them in the field. The purpose was to show them beyond medical college. So they were exposed to various startups in Ahmedabad, including IIPH, occupational health, Amul Dairy, Tribhuvandas Foundation, and including Arsh and in tribal area of Dang, how our people are working. So medical college is not only the prospective, lot of things to be done beyond medical college. And there was very positive response from the students as well as faculty, and we may be redoing it. You can see this is actually they learn what is going on in the field, sitting on ground, and sometimes they have stayed in the schools and used the public toilets also, things like that, right? So this is in brief what we have done as a team, and this will continue because this is one of the healthiest organization where we are not going in a lot of elections, but we are having a mutual team. So only office bearer changes, but the activities are always continue. And as far as theme of the conference is concerned, you all know it's about coming together for resilient health system. And the organizers mentioned here are example of that. Usually IAPSM and IPHA, bringing them on national level is a Herculean task. And here we are doing not only IAPSM, but also IPHA state conference as well as ACES. So I think this is one of the best example of building synergy for resilient health system. यस यस, महाराष्ट्र गुजरात तो एक ही थे ना, 1960 में अलग हुए. And IPHA state chapter of Gujarat, with effort of Dr. Deepak and Tapasvi, we were able to find out, and it is mentioned that IPHA Gujarat chapter was started in 1960 because it was separated from Maharashtra, but they were not able to print the constitution because there was no money available. And that's how this IPHA Gujarat chapter started. And as Vikas madam is witnessed that because there were so many stakeholders in IPHA, it was thought that there should be a separate only for the doctors also, so we can do some focused activity. That's how IAPSM was also born. And national chapter of IAPSM was also born in Gujarat. So I will not go in detail of that, but I will just end with what was shared by Zodpe sir and Deepak sir. We have crossed 75 years of independence. Life expectancy has almost doubled. Maternal mortality has reduced from 3 digit to 2 digit, but still many countries are in 1 digit. Lot of people are out of poverty, but the disease profile and burden has also changed. Communicable diseases are still there, NCD burden has increased. Undernutrition is still there, obesity is another challenge. And that's why we need to work as a team. And I'm confident with this collaboration, with available technology to help each other. Now world is very small, we are so much connected with each other, and all the people sitting here, we all can definitely work towards a better future, contribute actively on the same way. And that's the beauty of this collaboration, that we don't have only medical college people here or public health student here, we have also people working in the health system, as in the governmental system, WHO, UNDP, everyone is together. So I'm sure with collective effort of everyone, we will be able to bring a more happy and healthy world. So I will end with inspiration of Anurag Kulkarni sir. What is, we are always saying, Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschit dukha bhat bhavet. Thank you.
Thank you so much, sir, for your insightful thoughts. I now request Dr. Purushottam Giri, sir, IAPSM Secretary General, to please present his thoughts.
I will not take much time. I will finish within 20 seconds only. So, respected dignitaries on the dais, senior teachers, my colleagues, dear delegates. At the outset, being a National Secretary of this IAPSM, I take this opportunity to welcome you all for this grand 31st Annual State Conference of IAPSM and 30th Annual State Conference of IAPHA. Gujarat chapter is organized by IIPH Gandhinagar under the leadership of Professor Dr. Deepak Saxena and Anish Sinha. The theme of this conference is chosen very noteworthy theme for this conference is building synergy for a resilient healthcare system with a focus on the fostering collaboration across various healthcare sectors to enhance the strength and resilience of the overall system. The increasing frequency of descriptive events, particularly public health events for international concern, has demonstrated the critical importance of a resilient health system in safeguarding global health security and sustaining the progress toward the universal health coverage. Of course, events from the recent infectious disease outbreaks, including ongoing global COVID-19 pandemic, outbreak of Ebola virus disease in Democratic Republic of Congo and Guinea in 2015 in the West Africa, and the outbreak of Zika virus disease in 2015 and Middle East Respiratory Syndrome in 2012 have increased the recognition of this public health importance with the country's capacity to prevent, prepare, detect, respond and recover from public health emergencies while concurrently providing essential health services in dividend of the resilient health system. I am confident that this conference is so much meticulously planned with enriching scientific papers. Plenary sessions are being delivered by renowned speakers. This conference, of course, invites to explore, elucidate, and strengthen the role of community medicine physicians for long-term improvement and maintenance of health of the population. I am sure that the deliberation in this conference will ignite will ignite the minds of the community medicine specialists, public health experts, medical students, and academicians to chart out the intricacies involved in the theme. Especially, I heartily congratulate and extend my best wishes to Professor Dr. Deepak Saxena, organizing chairperson of this conference, and Dr. Ashish Sinha, organizing secretary of this conference, and their whole team for the organizing this grand conference with appropriate theme in the present times. I wish the conference will be academic feast for all of speakers and delegates. Let us look forward to gain meaningful practical insight in shaping the assured health policies for India. Last but not the least, I extend my best wishes for the grand success of the conference. Thank you. Thank you.
Thank you so much, sir, for your insightful few words. I would now like to request Dr. Anish Sinha, Organizing Secretary and Registrar, IIPHG, to address this gathering.
Honorable Chief Guest, Guest of Honor, distinguished guests, stalwarts, esteemed delegates, and my dear colleagues and students. It's both an honor and a privilege for me to extend a heartfelt welcome to you all on behalf of the organizing committee of this 31st Annual IIPSM Gujarat Chapter, 13th Annual IPHA Gujarat Chapter, and 7th ACES Conclave at IIPHG Gandhinagar. First and foremost, I would like to express my sincere gratitude to IIPSM Gujarat Chapter, the President, Secretary, and the committee entire for bestowing confidence and giving IIPHG an opportunity to organize this prestigious event. The event is the result of the tireless efforts of our students, faculty, and the staff, and the research colleagues. I would like to express our deepest gratitude to our esteemed chief guest, guest of honor, and dignitaries for gracing us with their presence today. And your insightful words have inspired and motivated us all, and we are truly honored by your support for this confidence. We are also deeply thankful to all our distinguished speakers and panelists of national and international repute who will be sharing their knowledge and experiences over the course of this conference. Your contributions are invaluable to the success of this event, and we are eager to learn from your expertise in public health, epidemiology, and other vital areas. A sincere thanks to our organizing team, volunteers, and all the staff at IIPH Gandhinagar whose hard work and dedication have made this conference possible. Your meticulous planning and execution have ensured that everything runs smoothly, and we are truly grateful for all your efforts, and the full house is a witness to it. Now, we are also like to extend our thanks to our various sponsors, the UNDP India, UNICEF Gujarat, Naira Energy, India Primary Healthcare Support Initiative from Johns Hopkins University, Astral Foundation, SHSRC Gujarat, Government of Gujarat, Ahmedabad Municipal Corporation, and other partners and stakeholders who have supported this conference. Without your generous contributions, it would not have been possible to bring together such a distinguished group of experts, researchers, and practitioners. Your support has been crucial in making this conference a reality. Finally, to all the participants, delegates, faculty members, and students, thank you for being here and for your continued commitment to the field of public health. We are confident that with this conference will provide you with a platform to enhance your knowledge, engage in meaningful discussions, and build networks that will last long even after the event. I am happy to share that yesterday we conducted 7 pre-conference workshops. The workshops were also supported by SHSRC Gujarat, ranging from qualitative methods to leadership skills. This was attended by over 250 participants. We have now 448 delegates participating in this conference, and there are around 40 nominations from different organizations. We have received 110 abstracts for oral and poster presentations, which will be held today and tomorrow. As we proceed with this conference, I hope each one of you will take full advantage of the sessions, workshops, and opportunities for collaboration. Together, we can make a meaningful strides towards improving public health across the nation. The conference will also be a landmark for the Indian Public Health Association Gujarat State Branch, as we are collectively making efforts to galvanize the IPHA Gujarat State Branch with IIPHG, our institute, designated as IPHA State Secretariat. Also, at this momentous occasion, I would like to share some proud milestones. IIPHG University will be celebrating a decade of establishment in 2025, and to mark this, we have planned series of events throughout the year, beginning with the prestigious Track 1.5 Health Diplomacy under the aegis of Ministry of External Affairs, Government of India, on navigating health system challenges, India's health diplomacy in Global South in January 2025. The event will be attended by diplomats of over 15 nations, along with senior officials from Government of India. Certainly, we will keep you posted about the events. Once again, thank you everyone for being part of this inaugural ceremony, and we look forward to a successful and engaging conference. Thank you and have a wonderful time ahead. Thank you all.
Thank you so much, sir, for your address. Moving on, it's time for an official launch of conference's souvenir. I request the dignitaries on dais to unveil the souvenir of the conference. At this moment, with this gathering, we would also like to relaunch the quarterly IIPHG newsletter. I would request the dignitaries to unveil the IIPHG newsletter and congratulate the editorial team and the faculty members for this.
Welcome to the relaunch of IIPHG Newsletter's 6th edition. We are delighted to bring you an insightful news. Insightful news.
Some problem with the video, but we have an insight here, and I request the readers to kindly go through the website. You can get the access to the newsletter there. A moment of great joy for IIPHG, where the stalwarts of public health are enriching the air with their inspiring presence, spreading the fragrance of knowledge and wisdom. IIPHG would bank on this opportunity and would like to take some moment out to honor these stalwarts. I would like to request Dr. Anish Sinha to felicitate Dr. Vikas Desai, ma'am.
I would now like to request Dr. Anurag Saxena to kindly felicitate Dr. S.L. Kantaria. Dr. Komal Shah to kindly felicitate Dr. K.N. Zanalia. Dr. Deepak Saxena to felicitate Dr. Pradeep Kumar.
Dr. Deepak Saxena to felicitate Dr. Pradeep Kumar, sir. I would now like to request Dr. Bhavesh Modi to felicitate Dr. R.K. Bakshi, sir. Dr. Sumen Saha, sir, to felicitate Dr. Mahua Mitra, ma'am. It should be an honor for these budding public health professionals to witness these stalwarts. Continue clapping, continue cheering. Dr. Mahavir Golecha, sir, to felicitate Dr. Jayesh Kasambia, sir. A big round of applause. Dr. Shalu Chaudhary to felicitate Dr. Murudala Lala. It's the morning time. Please continue clapping, continue cheering for these stalwarts. I would request Dr. Apurv Kumar Pandya to felicitate Dr. Deepak Solanki, sir. I would like to request Dr. Apurv Kumar Pandya to felicitate Dr. K.B. Patel, sir. Welcome, sir, with a loud round of applause. We should not let this moment go waste. I would request the stalwarts to please come on the dais. Let's capture this moment for memories. A group photograph is quite essential for this event today. Thank you so much, everyone. I now request the respected dignitaries and guests to take their seats off the dais.
Thank you all. an important announcement as we are slightly moving ahead with some delays. So I request now all, we will try to maintain the time frame allotted to all. So that's a request from our team. Thank you.
Moving on, as is customary, let's go ahead towards the part of the conference where we honor the distinguished experts in community medicine with the Ninad oration. We request Dr. Bhavesh Modi, IAPSM Gujarat State President, Dr. Atul Trivedi, IAPSM Gujarat Secretary, and Dr. Aparajita Shukla, IAPSM Gujarat State Vice President, to please join us on the stage. May I request Dr. Bhavesh Modi, Dr. Atul Trivedi, and Dr. Aparajita Shukla to please come on the dais.
Good morning, everyone. Ninad oration is conferred to a senior person from the field of preventive and social medicine or community medicine or public health as a recognition to his or her contributions in the field of the subject. The oration is conferred traditionally every 2 yearly, but for now, last few years, this has been an annual event. The orator is honored in the annual conference of the IAPSM Gujarat chapter. During the same, orator delivers his or her oratory speech to the gathered members of the IAPSM Gujarat chapter and participants of the conference. The oration is named after 4 eminent teachers of the subject to honor their dedication, hard work, and commitment towards the discipline. The word Ninad, N-I-N-A-D, is formed from the letters of the names of these teachers: Dr. Niyogi A.K., Dr. N.R. Mehta, Dr. A.N. Bhatt, and Dr. H.D. Trivedi. Ninad is also a Sanskrit word, and it means sound or voice. Ninad oration represents the voice of preventive and social medicine. So I'm very honored and privileged to announce the name of the orator of this particular Ninad oration today, Dr. J.K. Kosambia, sir. I invite him on the dais. I request Dr. Bhavesh Modi and Dr. Atul Trivedi to felicitate Sir. I invite and request Dr. Hinal Baria, Associate Professor, Community Medicine, GMERS Rajpipla, to come on the dais and introduce our orator for the day, Dr. Kosambia Sahib. Dr. Hinal.
Yes, respected seniors, colleagues, and dear friends. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Par Brahma, Tasme Shri Guruve Namah. Today, I am both an honor and a privilege for me to introduce my remarkable person that make a difference in my life, that is Dr. Kosambia sir. Being his student, I have learned a lot for him. His achievement has left an indelible mark on all of us, a person whose experience, wisdom, and integrity make a guiding light and a source of inspiration for all of us. He is my mentor, teacher, and a guide, and an accomplished professional, and a visionary whose work transcends the boundaries of personal achievements. With an introduction of Dr. Kosambia sir, he has an illustrious career spanning over 3 decades. Dr. Kosambia sir's contribution in preventive and social medicine is an example of unwavering dedication, profound intellect, and an enduring commitment to public health. He is currently serving as a professor and head of Department of Community Medicine at Kiran Medical College, Surat, and also he has held the esteemed position of professor and head at Government Medical College, Surat. His academic and professional journey is characterized by a continuous learning and global collaborations. He has trained in health management from University of Leeds, HIV and STI clinical research at University College Hospital in London, and the University of South Florida. His training and prevention of parent-to-child transmission at St. Jude Children's Research Hospital, Memphis, USA. His partnership with renowned institutions under the NIH Fogarty grants have significantly boosted HIV/AIDS research and training initiatives. We all know, since 1991, he is the stalwart in HIV/AIDS research, leading pivotal initiatives such as NARCO-funded targeted interventions among female sex workers of Surat city. His Groundbreaking work in these areas has not only advanced our understanding of HIV prevention, but also shaped our prior policies and practices that have positively impacted the vulnerable populations such as female sex workers of Surat City, and one of the dissertation is also sir has made on female sex workers. So it's inspiring an encouragement and learning journey with sir since many years. And equally notable, Kosambia sir is a role and mentor guide. He is the mentor of international PhD scholars from Emory University and University Hospital London, and MSc student from the London School of Hygiene and Tropical Medicines. He has served as a chairman of COVID-19 Epidemic Intelligence Unit for the Department of Health and Family Welfare, Government of Gujarat, as well as member of State Research Advisory Committee. His contributions to policy development implementation during the pandemic were instrumental in shaping an effective public health strategies and responses. His involvement in various ethical committees of prominent institutions reflect his commitment to upholding the highest standard of integrity and ethical practice in research. In addition to the governance and mentorship, he is an accomplished scholar and contribute 123 research published articles in national and international index journals. His editorial contribution to esteemed publications such as Indian Journal of Community Medicines, the National Journal of Community Medicine, and the Healthline Journal. Today, his receipt of his prestigious Ninad oration on 31st Annual State Conference of Indian Association of Preventive and Social Medicine Gujarat Chapter and the 38th Annual Conference of Indian Public Health Association GC is the testament of his legacy in public health. Dr. Kosambia sir, your vision, your leadership and expertise continue to inspire all of us, and on behalf of everyone present here today, I extend my deepest gratitude and heartfelt congratulations on this well-deserved honor. We wish may your life be filled with new achievements, joy and fulfillment. We hope that the road ahead brings you more opportunities to inspire all of us. Thank you, sir, for being a guiding force for not only me, but all of us in our lives. And we wish all the success and happiness in the years to come. There is a lot of to say and many more to say, but it's not enough on this stage to describe more. Thank you, sir. Thank you, everyone.
I invite Dr. Kosambia for his oratory speech now.
Very good morning to all of you. Respected teachers, my seniors, my colleagues, and my dear student, and all esteemed delegates of IAPSM GC conference, I'm very much delighted and happy today as a recipient of Ninad oration at IAPHG platform organizing this conference. So first of all, I want to thank you, IAPSM GC, for nominating me for Ninad oration. And this Ninad oration, as we've seen the introduction, these four stalwarts, in the name of these four stalwarts, IAPSM has started this Ninad oration from Surat only with the vision of Dr. Surat, and I had very long association with Dr. Mehta sir to me to change my entire career, how it is started and how I continue the work entire life for one cause, that HIV AIDS. So the first thing that my dissertation, that HIV, seroepidemiological study of HIV among the high-risk population in 1991. In September 1991, the Times of India reported that 10 bottles of blood banks turned out HIV positive, and it was the news for entire country and the Gujarat state. So at that time, the government of Gujarat, as well as our professor head at that time, Dr. D.M. Saxena sir, asked me, let's conduct a study on HIV, because the Surat has organized and exist red light area since more than 400 years. So we start a study among this group. And I said, sir, is it possible to enter in red light area? And sir said, yes, we can, why not? So he said me that only 50 samples is enough for your study. Do this is the wonderful topic for you. And I struggled for at least 7 months to enter in red light area for getting the sero samples from this particular group. So after every 15 days, I reached to my professor, Dr. D.M. Saxena sir, that please change my topic because it's very difficult for me to conduct this study. And many of my colleagues and friends, they told me that you are here to just pass out your MD, not as a researcher. So just finish your MD, get the passport, and finish your task. But Saxena sir was motivated for me to conduct this study, and we initiated with the help of politicians and other NGOs, but we were getting failure again and again. But with the support of the muscle man, we organized a camp in red light area for health checkup of these female sex workers, and luckily we were collected at least more than 150 samples from this particular group, and that was the history. And after that, Dr. D.M. Saxena sir has joined as a project director of Gujarat State AIDS Cell, and Dr. Vikas madam was my guide for complete this dissertation, and I completed in November 1993 with this topic, and that was a wonderful journey for me. And at that time, sir has lot of idea that only 150 sample is enough for female sex worker, but let's we conduct the similar study from one. And the AIDS cell established after the NACO established in August 1992 at New Delhi in the similar fashion with the mandate of the NACO. Gujarat State AIDS cell was established, and that was on the basis of the study we conducted in Surat. After that, NACO has provided one opportunity to conduct the highest behavior mapping at that time with Dr. Vikas madam, and Dr. Pradeep Kumar sir was the investigator, and I was with them, and conducted this mapping study, that is the qualitative study. But just for they came for the health checkup, and turned out HIV positive, and we continue to work with them. So Department for International Development, UK, we started this project in 1997. After that, lot of landmarks, things that happen at Surat level, that community-based STI prevalence study that we conducted at that time also, no any department was ready to conduct the STI prevalence study at community level. So when NACO has invited all the medical colleges at Delhi level, everyone says very difficult task, we were not able to conduct this study. Ultimately, the Surat did it and that the sample size, everything, volunteers, female from general community for Surat, because the positivity rate was highest, that 8% positivity in Surat district jail, and we started this project as per the NACO directive. Unfortunately, that was not sustained due to the government policy. So otherwise, that was a wonderful project that working with prison inmates. And other things that I will describe in coming slides, that we form a CBO community and getting this direct grant from NACO. So CBO that we established at Surat and that registered with government of Gujarat. So this is the landmark study, what I said with you the first time that we conducted in Gujarat, Surat in 1991, and the highest positivity reported from female sex workers of red light area, that is 18.5%, second highest in India, next to Mumbai. Mumbai reported 30% HIV positive at that time. And so everyone alarm that what to do for this HIV problem in Gujarat and particular in Surat. So at that time, similarly, you see these different group, STD patient reported 3.5% positivity, prisoners 5%, and rest diamond worker, SRP Jawan, truck drivers. And one thing I wanted to share with you, that very difficult group, that IV drug users, I conducted the 12 samples from this group on Sunday and collected the sample and stored in the blood bank refrigerator. And at that time, Professor Head Pathology said that just thrown away all the samples because they may be HIV positive and we don't allow to keep in storage at our lab. So that was the fear in mind of all the medical faculties, all the academia, what to do with HIV samples collection. So at that time also very difficult situation we faced in our hospitals also. And as you know, familiar for the Surat city, that Surat was an engine driving for HIV epidemic in Gujarat. And today also the Surat contribute 25% HIV positivity in Gujarat. So at that time, Surat was recognized as epicenter of HIV of Surat city or Gujarat state. But today I can say very proudly that it is at forefront of prevention program of HIV, not only in Gujarat, but even at national level also. That's due to our efforts. And for that, we started this Paras PSM NSCP projects after defeat withdraws the National AIDS Control Organization. They took over to continue this project, and this is the only one project in entire country run by a government organization, that is in Medical College, Department of Community Medicine. So we are very proud for this Paras PSM project. This is the area map. You can see that the very high density and the migrant populations, everyone get the opportunity of a job here, zero unemployment here in Surat city. So migrant population, they are visiting city, and they become the vulnerable population for these. I will discuss this in later on slide, what exactly happened when we conducted the pilot projects. So under this Paras project, we estimated that more than 13,000 female sex workers in Surat city, and out of them, more than 7,062 sex workers, they are under coverage of current status. And from them, 93 turn out HIV positive. And we can say very proudly, all 93 are availing ART services, ART pills from ART center. So 100% coverage of all PLHIV female sex workers with ART centers. And we had the vision to work with female sex workers' children. And for that, we are continuously working for the safeguard of these children, providing the safe environment, keeping them in hostels, the residential hostels. So currently they are having 6,834 children, and we have the cumulative efforts providing the hostel of these children of sex workers in Surat city. So after that, we conducted this zero prevalence study with support of FHI. That's in 2000. And after 1991, this was the study with all etiological agent, all antigens, and all PCR facility available with FHI funded projects. So we reported that 43.9% positivity, HIV positivity from this group, and gonococci, chlamydia, RPR test. And from this publication, still you can search Google or NACO website, you find our journals papers here that on the basis of this study, NACO has replicated these presumptive periodical treatment projects throughout the country. So we can take proud for that also, implementation of PT, presumptive treatment for gonococci and chlamydia infection among HRG group. Then if you see the trend, then you can realize that in 91, 92, the reports positivity 18.5%, in 2000, 43%. But after that, with the efforts of the project, it continues decline, 11%, 7.5%, then 8%, then 4.4%, and 0.8%. Recently, we can say that again, it remains at the line of 0.6 or 0.7% positivity among the female sex worker. So this is the impact that we've seen from the projects. And we compare with the Gujarat and Surat with 1991, then you can see that the positivity among the sex worker 18.5% and today 0.6%. That's the remarkable achievement that we had today. If you compare with the Gujarat, then also Surat has very declined trend in all the groups like ANC, female sex worker, MSM, TG, IDU, long distance truck driver, single male migrant, prison, STI clinic. Everywhere you see the decline trend at Surat. So that happens due to the collective efforts of all the communities, TIs, and medical fraternity. They provide the services to all PLHIV, and that resulted. So we can say that now it is no more epicenter, but it is at the front foot for preventive program at state level as well as national level. So we formed this CBO. If you see this data, then you can realize that we registered these Mahila Mandals, community-based organization with government of Gujarat. Can you imagine the things that in Gujarat government we can register female sex workers organization, but this happened at Surat. If you see these 2 registered CBOs with government of Gujarat, and they are getting the direct grant from NACO. And we provided them the platform as a democratic view. They elect their president, their secretary, they receive members, and they run entire show. This is the typology. If you see the earlier, it was the brothel based, the only organized zone in within the city. Now they are spread out in entire city outside red light area. Now the home-based sex workers are many more street-based sex workers. But recently, the mini brothels, one owner or one madam with 2 or 3 sex workers, they are running the business. Same way, the spa and beauty parlors, increasing trend of female sex worker working in this particular group, typology, guest house, OYO, call girls, and virtual platform. We conducted this study for female condom acceptance from funded by FHI, and that was not get the success in among these female sex workers, but we tried these. Then we established field-based STI clinic, and the efforts that we trained our resident doctors, not only PSM, but the dermat resident and gynec resident, even microbiology, and they used to visit our DIC, and they run the DIC clinic and provide them treatment, syndromic management. We train these residents for management of syndromic management. And from that, our dissertation, some of the study, as Dr. Hinal mentioned, that conducted at DIC level, and this is the publication on the base of that the presumptive treatment was selected by NACO, and we got the other PhD students on the basis of this publication. So this presumptive treatment that the project we got for randomized cluster trial among the female sex workers, but that didn't happen. I will tell this story again later on. But azithromycin 1 gram and tablet cefexin 400 milligram, that was the drug given for presumptive treatment approved in advanced syndromic management by NACO. Lot of crises happen among these female sex workers, and that hampers our program of condom promotion as well as counseling and screening for STI. So that happens from the police, gundas, and clients also. They are vulnerable with their regular clients as well as their visiting clients, where they get the episodes of crisis. And if you see the lower line, then the violence per female sex worker that reported 10 per sex workers from police, and Gunda 7 per 1 and 15 from clients. So that's the environment where we want to work for the promotion of the condom and for this program. So if you see this model, then you can realize that once there is a crisis from client, police, or Gunda, then what happens? They directly adversely affects utilization of STD services. There is no treatment of STD, and that hampers our program. And they have to go for the cost of legal procedure and compromise their condom use and negotiation with their client, because they are worried for their children and they have the fear of hunger, and that ultimately affects our projects. So Surat Municipal Corporation has established one urban health center within the heart of this red light area, and they provided the land 2 floor for CBO to work for DIC, dropping center for them. So that was the vision of Surat Municipal Commissioner and entire body. And during 2003, there was the police action, and they locked down the red light area of Surat city. and at that time what happened for the condom promotion and availing the services. If you see this bar chart, then you can realize that earlier we used to sell or distribute the condom more than 6 lakhs, that reduced by 3.5 lakhs among this group, and it hampered for the social marketing also, as well as utilizing of clinic also. If you see in 2003, dramatically reduced in utilizing the services of STI and syndromic management at this clinic. And that not only for the sex worker, but if you see the entire city, then you look to this proxy indicator of ANC positivity, because all ANC mothers and the positivity among ANC mothers that reflects for general population, they are the proxy indicators, and that increased by after 2003. Earlier it was less than 0.5%, but after 2003 it increased more than 1%. That gives up alarm that what happens if there is a police action among this particular group, as well as new civil hospital data of STD clinic. If you look for 2003, then again rise in STD clinic attendee. So not only for female sex worker, but all the citizens, they are at risk once the drastical steps taken for lockdown or harassment of the sex worker. We conducted one pilot project for a cross-border state, because in Surat city, we are having the migrant population from Orissa. They are working in textile industry. And suddenly the ANC positivity reported in Ganjam, very high positivity. So they blame Surat. Ultimately, they blame Surat because from migrant, they reaches to their family, and they infect their housewife also. So increasing in ANC trend at Orissa or Ganjam, they blame Surat, just like Munni Badnaam hui HIV ke liye. So Surat was blamed for HIV. Everyone says that from Surat we are getting the infection. Not only the Orissa, but in Saurashtra also, when diamond recession happened during 2008, then Amreli, Bhavnagar, Junagadh reported high positivity. And they again blame Surat, that from Surat the infection spread to here. So we started this cross-border project, source and destination project with Ganjam, and their higher officials, they visited Surat. And I wanted to share with you that what is the comment of the Labour Commissioner of Orissa when Dr. D.M. Saxena sir was expressing all the scenario of Surat and Gujarat, what's happening for with the in-migration of Ganjam and how we can plan this source and destination project. So Labour Commissioner said that you have employed, given the employment of these minor people, and they want to penalize Gujarat government. That's this many number of minor population, they are working in diamond industry. So we are very sorry that we are working for one noble cause and they diverted entire issue differently. Then we work for the children. That was our motto, that their children must be safe and from this environment, away from this environment. So they said that my child won't follow my footsteps. It was my helplessness that led me into this field, and I won't let that happen with my children. I want my child to be educated and not helpless like me. It is hard to be away from her, but it is for the greater good that she stays away. So we put these children in the residential school. And when we interview these children, then they say that home is better place for stay. Even though they say that if I want here, I would just be doing housework at home. I like to study and I want to get a good job when I grow up and help my family. These are the words of the girl child resides in juvenile home. Not only that, when we organize the function at department, they wanted to become a doctor also because they are sitting in the lecture hall of community medicine department. And this is for their school Chale Hum project. That was one study conducted by MSc student of London School. And with the help of, I wanted to acknowledge Dr. Pradeep Kumar sir. He was the APD, Additional Project Director of Gujarat State Aid Cell at State Society at during 2008. So he provided huge amount of money to start dropping center at the department only, in the medical college only, with the motto of mainstreaming of all the activity of HIV control and sensitizing this postgraduate student and UG student and linkages with the hospital, that when they visit the hospital for treatment of STD or gynec problem or any other issue, the resident doctor may recognize them and they provide non-judgmental, with the non-judgmental attitude treatment to all the female sex workers. So thanks to Dr. Pradeep Kumar sir to start that DIC at Community Medicine Department only, and we had a lot of publication. With that, we conducted this outbreak investigation like the syphilis outbreak among this red light area published in our own journal. And one more, that qualitative study done by Bansri Chawda. We used to invite this health minister, late Ashok Bhatt, and he used to visit the red light area for Raksha Bandhan event every year. So that was the motivation, and the sex workers were empowered to talk the health minister as well as collector, mayor, and police commissioners also. The success story, as I already narrated, that due to this, not only from female sex worker, but MSM, STD, and ANC rate also declined. And that is also not success for decline in HIV, but decline with cost effectivity. And we recorded this cost-effective impact evaluation with the one of PhD study by Dr. Mamta Verma in department. So if you look to the data, then you can realize that cost per one infection average, that is $98 among these female sex workers, and in entire country, that $106 dollars for that. Now coming to the next chapter, I am thankful to Dr. Bugsy and Dr. Majmudar sir that when USF, University of South Florida, contacted them and they signed MOU with them, but they diverted their focus with GMC Surat because the population or HIV positivity is high within the Surat, and we have the many programs. So we signed MOU with University of South Florida, San Diego, and St. Jude Children Research Hospital for conducting the research and training with this university. So we got, these are our collaborators. Many of you know them personally also. And Dr. Pat Emmanuel, Dr. Aditya Gaur, our own alumni at St. Jude Children's Hospital, Memphis, Kristen Well at San Diego, and our friend, Dr. Ambuj Kumar. Many of you recognize him. We got this grant. Thanks to Dr. Bugsy again. And we got many more grants, Fogarty grants, not only these at RIP, but others continuing with these USF projects. And for the capacity building, not only community medicine department, but we took other departments with us at US, like medicine department, ART centers, then microbiology department, then pediatric department, gynec department, and pharmacology department. You see the Jaykaran also here. So it's a collaboration within the college. So with my department, other faculty members also got the opportunity to visit that. And I am fortunate enough to train for advanced course of STI HIV management, clinical posting also at University College Hospital London, USF, and thanks to British Council for my 3-month certificate course at Nuffield University, Leeds. So these are my international training, and we monthly conduct the webinar, and from the Surat, total 6 faculty and residents that delivered talk, and same were the dissertation supported from the international collaboration. Mainly for the qualitative research they supported from USF only and pediatric department also. And this is very interesting, cross-learning, because Dr. Pat Emmanuel, the PI of this Fogarty grant, told me that why your resident writing email to me through you, empowered them to directly talk with me. So Dr. Jill and others, Saili, they write email, they directly talk to the PI, international PI. That kind of empowerment of residents that happened under this grant. Then second, networking that you see that we did the networking with many organizations, not in India, but US, UK also. This is the picture of University College Hospital, Dr. James Rickens and Dr. Ian Weller, one of the HIV specialists, international world-renowned HIV specialist at University Hospital, London. This is the interesting story. I don't have much time, but I want to say one interesting story that when we received this randomized cluster trial funding from Population Council that time, due to some problems in our state, that fund was transferred to CMC Vellore, and we could not conduct this randomized control trial. But we got the opportunity from CMC Vellore. They came to PSM GMCS and conducted many workshops. Many our stalwart, they know Dr. J.P. Mulai and this Pratap Therian, one of my friend. They came to Surat and taught us for ethics, Cochrane review, and from GMC Surat, 6 faculty visited CMC Vellore for workshop, and they charge nothing, free of cost. One of the PhD students from Atlanta, Emory University, Dr. Silpa Patel, we conducted serodiscordant couple study, and that policy made the change that at couple counseling is much more needed, family counseling is much more needed at ART center, and Positive Jivan Sathi project that we conducted with the support of Emory University. At UCL also we conducted the study that the male migrants, and that is also one of the PLAWS publication, and that started the migrant projects in India and Surat. We conducted this trucker project constantly for two years. You see the picture of Mr. Rakesh Asthana, Police Commissioner, Mr. Pargi, and Sobha Bhutra, DCP at that time, and the positivity rate you can see here that 1.25 and next year 0.59 truckers. We work in prisons also, the prison positivity, the publication you can see differently. Then textile market also. We did the advocacy. I want to take few minutes for these, that we did the advocacy for ART center at New Civil Hospital. Because as per the NACO mandate, NACO has provided funding every state for one ART center that naturally start with the capital, that's the BJ Medical College. But we did the advocacy with Dr. Amarjit Singh sir at that time of the health commissioner, that Surat has the highest positivity, highest number of the people, positive people, and we need the ART center. So he directly sanctioned 29 lakhs rupees to establish ART center at New Civil Hospital. So that ART advocacy works. Same with OST center, oral substitution therapy funding goes to NGO, but first time in New Civil Hospital that goes to psychiatry department, and we conduct, this is interesting story of Sujata Rao. At that time, the transition period of DM Saxena sir, he retires from AIDS control cell, and Dr. Pradeep Kumar sir has taken over the charge. And DG NACO, Sujata Rao, closed down all migrant projects of Gujarat state. When she visited Surat, we took her to migrant area, particularly in Orissa area. She realized that only 20 females per 1,000 male working in this particular area. So she said that, why are you not working for this particular migrant projects? I said, madam, you all later stop down all the migrant projects. So she said that, I am here up to evening. Please come to airport with a written letter. I can sign this letter to restart this project. And Dr. Pradeep Kumar sir was the witness for that. At that time, she signed this, and migrant project continue. We have the lot of story to share, but due to limited time, I cannot go in detail. But we are doing this webinar every monthly, but sustainability is a problem. And one thing that we are looking forward for adjunct professorship, and that file lies with the DMRE. Once again, I request Dr. Atul Bhai to take note of this, that at least we can give them adjunct professorship so they can work co-guide for any dissertation or PhD projects. Same way, the USF resident, they visited civil hospital, their UG student visited civil hospital Surat, but unfortunately we are not having the guideline from government of Gujarat to send our resident to US, so that is the unfortunate part. Okay. COVID, we worked, you know that I was the chairperson of epidemic control unit, and this was the SERE model. Every day we used to present to these. And this is the quiz for PG. You can see this picture and realize who is this person, and had said that this is the first AIDS case in entire world. So at least if you can find out from Google, who is that? So this many dissertation we did. And this is the achievement. I take only few minutes that Dr. Samudyata constantly winning and made the hat trick for HM Patel Trophy, and always trophy goes to GMCS. So we are very proud for that. You see the list of the trophy winners. Same way at AIDS Asia Society, Dr. Samudyata got the first prize every time, and country director Bilali Kamra, he directly messaged me that your student performing wonderfully at national level and we want to collaborate with you. At Kiran Medical College right now, I am having 4 projects. One very ICMR funded project, malaria control trial, that we are conducting here. I acknowledge my mentors, all the people who supported, who guided, who shaped my journey. Thanks to PSM, GMCS and Para staff, and my wife, the support always I receive from her to conduct this. Thank you. Thank you to IAPSM. Thank you IIPHG. And lastly, यही कट जाएगा सफर साथ चलने से, दीपक कि मंजिल आएगी नजर साथ चलने से. Thank you all.
Hello. Thank you. Big applause for our Kosambia sir's mesmerizing speech. Sir, your speech has given us a lots of insight and vision. It shows about your commitment and dedication. And sir, it shows and speaks about how the policies now or the research is not done only for the publication purpose, but how the research is made and converted into the policies and up to the planning level and up to the implementation level and up to the people where they are the beneficiaries who are get benefit of it. So sir, it's a really remarkable speech, sir, and lots of learning lesson for our PGs and our young professionals, that how to go ahead and how to commit yourself with the interest and go ahead. There is a karwa banta jayega, chalte jao karwa banta jayega. Sir, you have proved that, and we are thankful for your mesmerizing speech, sir. It's a commendable speech, sir. Thank you, sir.
This must be the finest moment of today. The sketch of Kosambia sir is a token of respect from Team IIPHG, curated through the creative efforts of the artists from IIPHG. We should applaud their efforts today. This moment to be captured. Now proceeding ahead for Param oration, we would like to invite Dr. Bhavesh Modi, IAPSM Gujarat State President, Dr. Atul Trivedi, IAPSM Gujarat State Secretary, and Dr. Chandresh Pandya, Gujarat State Vice President, on the dais. We hand over the stage to Dr. Bhavesh Modi to carry forward the proceedings for Param oration.
For Param oration, we have a committee chaired by Dr. Chandresh Bhai. I request him to brief about the oration.
Thank you, Bhavesh Bhai. This Param oration was started by the IAPSM Gujarat chapter. This is also known as Dr. Raval Award, aims at improving oratory skill by listening to a good orator in the relevant topic. The award includes the memento, certificate, and felicitation of the orators, and recipient selection is based on the certain criteria. He or she should be a very good orator, known for his or her skill of oratory and lecturing, and not only the skill, but working or practicing or teaching or training or in the field of preventive and social medicine, community medicine, public health, social or behavioral science, humanities or social work, or any other related to humankind. And this award is not considered based on any seniority, age, or sex, or on the basis of any other criteria. And this time, this award, this oration has been offered by to Sri Dilip Deshmukh sir, Angdan Charitable Trust. I'm inviting sir to come on dais. Dilip Deshmukh sir. Big round of applause to sir. I request President and Secretary sir to felicitate with shawl. Sir, please. The dais. What's here? Felicitation. Sir, please. I request Dr. Chintan Chaudhary to introduce Sri Dilip Deshmukh sir for this oration.
Good afternoon, everyone. Respected Dada, respected Bhavesh sir, Chandresh sir, Atul sir. It is a very blessed moment for me to introduce Dada. Dada born in Maharashtra. He moved to Gujarat in 1983, dedicating his life to social service as a full-time pracharak. Over the years, he has worked tirelessly across various regions of Gujarat, including Surat, Mehsana, Kutch, making significant contribution to society. Shri Dilip Bhai played a key role during critical moments in Gujarat history. He was actively involved in relief work during the plague outbreak in Surat and worked relentlessly during the rehabilitation efforts following the devastating Kutch earthquake in 2001. For the past 2 decades, his focus has been on the holistic development of Kutch. His efforts include education. In education, he is mentoring a high school in Bidada village, which has led to a remarkable rise in girls' education in the region. He is
रजिस्ट्रेशन किया है ऐसे केवल 1200 लोग हैं। तो बाकी जो लोग हैं 20,000 माइनस 1200 इतने लोग जो है वो ट्रांसप्लांट करना ही नहीं चाहते हैं। और क्यों नहीं करना चाहते हैं? डर के कारण करना नहीं चाहते हैं। जितने लोग अंडरगोइंग डायलिसिस है उसमें से 50% लोग 3 साल के बाद हो जाती है। तो ये जो मैंने 2 शब्द आपको कहे, अमृतकाल और विकसित भारत, दुनिया में जितने विकसित देश है वहां कहीं भी ऑर्गन की प्रतीक्षा में लगभग किसी की मृत्यु नहीं होती है। तो हमारे देश के विकसित भारत का टारगेट मोदी साहब ने रखा है 2047 तक। तो जल्दी से जल्दी हमारे देश में स्थिति आनी चाहिए कि किसी का अगर ऑर्गन फेल्योर हो गया है तो जल्दी से जल्दी उनको ऑर्गन मिलना चाहिए और किसी जीवित व्यक्ति को अंगदान न करना पड़े, ऑर्गन डोनेशन। इसलिए यह सारी अंगदान की मूवमेंट चल रही है। लीवर के पेशेंट अगर आप हॉस्पिटल में जाके पूछेंगे कि अभी कितने पेशेंट वेटिंग लिस्ट में है, लीवर फेल्योर के पेशेंट काफी सारे हैं, लेकिन आप वेटिंग लिस्ट में पूछेंगे तो बताएंगे 40-50 पेशेंट है। तो मैं जो ये आंकड़ा बोल रहा हूँ आपको कॉन्ट्राडिक्टरी लगेगा। तो मैंने एक बार मेरे डॉक्टर को पूछा कि 40-50 केवल पेशेंट है लीवर के, तो उन्होंने कहा ज्यादातर पेशेंट 3, 4, 6 महीने में मर जाते हैं। हार्ट या लंग्स के पेशेंट है, मैं जितना अभी चल के वहां से यहाँ आया इतना भी हार्ट या लंग्स के पेशेंट चल नहीं पाते हैं। कभी कभी पिछले 5 साल से मैं काम कर रहा हूँ, ज्यादातर लोग हर दिन एवरेज 2 से 3 पेशेंट मेरे साथ ऑर्गन लेने के लिए अप्रोच करते हैं। तो जो लोग ज्यादा ऐसे पूछते हैं कि कोई जल्दी हो सकता है क्या और सरकार कुछ करेगी क्या, तो मैं उनको मजाक में बोलता हूँ कि भारत सरकार शायद आपको भारत रत्न, पद्म भूषण, पद्मश्री दे सकती है लेकिन ऑर्गन नहीं दे सकती है। बोला ऐसे कैसे होता है? तो मैंने उनको एक उदाहरण देता हूँ कि हमारे देश में एक व्यक्ति ऐसे है कि जिनको भारत रत्न मिला है लेकिन किडनी नहीं मिली है। तो किडनी मिलना कितना मुश्किल है ये बात बताने के लिए मैं ये बात बताता हूँ। तो ये बात आपके मन में भी आया होगा कि ऐसे कौन आदमी है कि जिसको भारत रत्न मिला और किडनी नहीं मिली। उस व्यक्ति का नाम है डॉक्टर जयप्रकाश नारायण। बहुत बड़े लोक सेवक थे, इमरजेंसी में पूरी सरकार उनके कारण बदल गई थी। तो ये ऑर्गन डोनेशन के विषय में मैंने कुछ डाटा आपके सामने रखा और वर्तमान स्थिति भी रखी। 5 लाख से ज्यादा लोग ऑर्गन की प्रतीक्षा में है। आपके संपर्क में ऐसे कोई पेशेंट होंगे तो उनको आप लिविंग डोनेशन खास करके लीवर किडनी में करने के लिए बोलिए, क्योंकि पिछले 5 साल से हम लोग काम कर रहे हैं तो ऑर्गन डोनेशन की रेट बढ़ गई है। हमको अवार्ड्स भी मिल गए, लेकिन अभी मुझे एक किडनी ट्रांसप्लांट सर्जन मिले तो उन्होंने ये कहा पिछले 2 साल में लिविंग डोनेशन कम हो गया है। तो मेरी आपसे अभी कुछ पेशेंट को मैं ये भी बता रहा हूँ कि लिविंग डोनेशन भी आप करो। तो ऑर्गन डोनेशन के बारे में मैंने बहुत छोटे में आपके साथ कुछ बात की है। हमारे जो पिछले 5 साल में प्रयास रहे हैं, यानी अंगदान जागृति रथ निकाला है, ऑर्गन डोनर्स की कोई किताब नहीं थी, हमने 2 किताबें पब्लिश की है, एक शॉर्ट फिल्म पब्लिश की है, पदयात्रा निकाली है। मेरे कम से कम हमारे पूरे ऑर्गेनाइजेशन के 5000 से ज़्यादा कार्यक्रम हुए हैं। अक्रॉस गुजरात मैंने 2 लाख किलोमीटर से ज़्यादा ट्रैवलिंग किया है। और मैं जो बोल रहा हूँ तो मेरी सर्जरी हुई 2020 में, जुलाई 2020, 10 जुलाई। आई वॉज डिक्लेयर्ड डेथ ऑन टेबल केस। तो जो आदमी आज आपके साथ बात कर रहा है वो 9 जुलाई 2020 को डेथ ऑन टेबल था। और लीवर ट्रांसप्लांट होने के कारण, क्योंकि ज़्यादातर मुझे लोग ये पूछते हैं कि ट्रांसप्लांट के बाद में जीवन कैसा है, ट्रांसप्लांट के बाद जिंदगी कैसी है। तो आज मैं ना ही मास्क यूज़ करता हूँ, केवल एक दवा मुझे दिन भर लेनी पड़ती है, दिन में 2 बार लेनी पड़ती है, लेकिन एक ही दवा लेनी पड़ती है। और ट्रांसप्लांट अगर समय सर हो गया, समय पर ट्रांसप्लांट हो गया तो बहुत एक अच्छी क्वालिटी लाइफ हम जी सकते हैं। मैं जब 59 साल का था तो मेरा ट्रांसप्लांट हुआ था, 4-5 साल हो गए, तो मैं बहुत एक अच्छा जीवन जी रहा हूँ। जो आप खा सकते हो वो सब कुछ मैं खा सकता हूँ, आप जो कर सकते हो वो सब कुछ काम मैं कर सकता हूँ, एक नॉर्मल जिंदगी। और मुझे कहने में बड़ा आनंद होता है कि जिस हॉस्पिटल के साथ जुड़कर हमने सबसे ज़्यादा काम किया वो सिविल हॉस्पिटल अहमदाबाद के साथ जुड़कर हमने काम किया। सिविल हॉस्पिटल अहमदाबाद से पिछले 4 साल में 174 लोगों ने ऑर्गन डोनेशन किया है। और 174 ऑर्गन डोनर्स के कारण 565 लोगों को नई जिंदगी मिल गई है। किसी व्यक्ति को नए जीवन का 1 मिनट भी देना, क्योंकि आप 1 मिनट भी अगर कितना भी पैसा खर्च करेंगे आपको ज़्यादा नहीं मिल सकता है, लेकिन मुझे कहने में बड़ा आनंद होता है कि 565 लोगों को नई जिंदगी मिल गई है। ये काम करते करते कोई आध्यात्मिक अनुभूति भी होती है। आप सब लोगों ने भगवत गीता का एक श्लोक सुना होगा, पेपर में कई बार पढ़ा होगा। इस श्लोक की अनुभूति में मैं रोज करता हूँ। 5000 साल पहले हमारे एक धार्मिक पुस्तक में लिखा गया श्लोक है। वो श्लोक का अनुवाद पढ़ने के बाद हम सब लोग विज्ञान के साथ जुड़े, हमको लगता है कि यह क्या बात सच हो सकती है। वो श्लोक है, नैनम छिन्दन्ति शस्त्राणि नैनम दहति पावका न चैनम क्लेदयन्त आपो न शोषयति। आपको कोई शस्त्र मार नहीं सकता है, कोई अग्नि आपको जला नहीं सकता है, कोई हवा आपको सुखा नहीं सकती है, आप तो चिदानंद स्वरूप हो। तो इसकी अनुभूति मुझे अंगदान के कारण हो गई। अंगदान किसी व्यक्ति का होता है तो क्या होता है, तो कई बार कोई अंगदाता होता है तो उसके फ्यूनरल में मैं जाता हूँ, उसके प्रार्थना सभा में जाता हूँ। हमारे चैरिटेबल ट्रस्ट के कारण अलग अलग प्रकार के काम हम लोग करते हैं, लेकिन ऐसे जब फ्यूनरल में जाता हूँ, जब एक अंगदाता का फ्यूनरल होता है, उसमें संस्कार होता है, उसी समय हमको जानकारी मिलती है कि उसका हृदय किसी मुंबई के, अहमदाबाद के, सूरत के हॉस्पिटल में काम करना चालू हो गया है। एक कोई आदमी जल रहा होता है और उसी समय उसका हृदय उसका काम करना शुरू हो गया होता है। मैं कहता हूँ कि वहाँ जिसने धड़कन चालू कर दी वो कौन है, और यहाँ अग्नि में जो जल रहा है वो कौन है। तब मुझे श्लोक आता है, नैनम छिन्दन्ति शस्त्राणि, ये आता है। तो आप ये काम प्रत्यक्ष लोगों को नवजीवन देने का काम है, एक आध्यात्मिक अनुभूति भी आपको दे सकती है। आप सब लोगों को मेरी विनंती है, इसके लिए नेशनल लेवल पर अथॉरिटी है, नोटो, नेशनल ऑर्गन टिश्यू ट्रांसप्लांट ऑर्गेनाइजेशन, वैसे स्टेट लेवल पर है। इसका पूरा मॉनिटरिंग ये नोटो और सोटो के माध्यम से होता है। इसमें किसी भी प्रकार का ट्रेडिंग नहीं है। जो अंगदाता है उसको पता नहीं किसको ऑर्गन जा रहा है, जो अंग लेने वाला है उसको पता नहीं किसका ऑर्गन मिल रहा है। तो ऐसे एक अद्भुत काम 21वीं शताब्दी में अपने देश में, अपने राज्य में हो रहा है, और ये काम करने की एक अनुभूति प्रतिदिन हमको मिल रही है। यानी ये 174 लोगों का ये 4 साल से भी कम समय में अंगदान हो गए, बहुत बड़ी उपलब्धि है। अपना देश जल्दी से जल्दी विकसित बने और अपना देश जल्दी से जल्दी ये अमृत काल में किसी को भी अंगों की प्रतीक्षा न करनी पड़े, इसलिए काम कर रहे हैं। विवेकानंद की एक बात कहकर मैं मेरी बात समाप्त करूंगा। विवेकानंद जी ये कहते हैं, दे अलोन लिव दोज हु लिव फॉर अदर्स, रेस्ट ऑल आर डेड। आप सबको मेरी विनंती है, लेट अस लिव फॉर अदर्स, लेट अस लिव फॉर अदर्स। थैंक यू सो मच। अंगदान महादान। थैंक यू वेरी मच।
Thank you, Dada. He is a living example of public health practice and inspiration for many of us. May I request now Dr. Deepak Saxena, Dr. Chintan and Dr. Anish Sinha to present a token of appreciation on behalf of IIPAG and on behalf of all of us. And this was the purpose of starting this Param oration. Someone who is may or may not be from our branch, but actually working from a public health and inspiration for all of us. Thank you.
जोरदार तालियों से सर का सम्मान करेंगे। सर एक प्रेरणा है हम सबके लिए। थैंक यू सर। Moving on to our next section, the Plenary 1, on the health system strengthening. The health system strengthening agenda focuses on improving healthcare delivery, resources and governance to achieve better health outcomes and equity. The key objectives include fostering functional links between health programs and system-enhancing organizational responsiveness, and effectively utilizing institutional resources. Without wasting another moment, we would like to invite the chairs for this plenary today, Professor Sanjay Zolpe, the President, PFHI, and
Dr. A.M. Kadri, Executive Director, SHSRC, Gujarat. Please join us on the stage here, sir. Dr. A. Kadri is the Executive Director of the State Health System Resource Center, SHSRC, Gujarat, since 2019. With over 25 years of expertise in community medicine, he has held key roles including Professor and Head of the Community Medicine Department at PDU Government Medical College, Rajkot, and Joint Director of the Gujarat State AIDS Control Society. Dr. Kadri was a technical lead during the COVID-19 response in Gujarat and has served as the National President of the Indian Association of Preventive and Social Medicine, shaping public health policy and systems in the state and beyond. A loud round of applause to welcome sir. I would like to request Dr. Chiranjeev Bhattacharya, Program Analyst, Health System Strengthening Unit, United Nations Development Program, India, on the dais. Please welcome sir with a loud round of applause. I would like to request Ms. Madhvi Mishra, Senior Program Officer, Indian Primary Healthcare Support Initiative, on the dais. Dr. Hemant Shah, Public Health Expert and Consultant, BMGF. I would now like to hand over the stage to the esteemed chair to introduce the speaker of the plenary and take the plenary forward.
Thank you. Good afternoon, everyone. Health system strengthening. I think this plenary session is very important when it comes to the community medicine and public health people. I always say that the people who are working in the community medicine and the public health have to learn about the system, typically what we are for the respiratory system, system for the GIT or neurology system. Similarly, we have to learn about the anatomy, physiology, biochemistry, pathology, and the pharmacology of the health system as well. And that's why, unless otherwise, if you are not having good understanding about the health system, you can't be a good health public health professionals. So I'm happy to chair this session, which is very important. I think the newer role of the as public health professionals, and today we are having distinguished luminaries who have vast experience in the public health. I take an opportunity to give an introduction of the first speaker, Dr. G. Bhattacharya ji. He is a medical graduate, public health expert
with the experience of working with various national health program from district to the national level. Currently, he is working as a program analyst, health and supports in UNDP India's work on digital health, HIV, LGBTQ health and rights, and neglected tropical diseases, and One Health as well. His key areas of interest includes the infectious disease epidemiology, One Health approach, and health system strategy. He is strong advocate of using the evidence for making decisions in public health and has contributed in various national and international journals as a peer review and experts. He is currently a member of the CII National Public Health Council and contributes to various national forums like NTAG, Rabies National Committee, and Second National Survey for Extent, Pattern of Substance Use in India, etc. And I have a distinct experience of working with when I was at the Gujarat State AIDS Control Society. At that time, he was working as an epidemiologist at the NACO level, so I have also got a personal experience of working with him. So thank you very much, and we will requesting to share your views.
Thank you, respected Chair. Very good afternoon, everyone. Respected my esteemed panelists on the dais, respected audience, dignitaries and delegates. So it's a privilege for UNDP to collaborate with IIPHG for the conference, and as a development partner, we work closely with both the national government, Ministry of Health and Family Welfare, as well as the government of Gujarat on our interventions. And I think this is an app platform where we would like to share our experiences in the last few years in terms of digitalization on the Indian public health system, which is going a long way in building resilience of the system. So that's where I will focus my talk on. So quickly, without waste of time, I will move with my presentation. So in this presentation, I will be talking about use of various national level digital health initiative which UNDP has rolled out across the country in the last 10 years. So our journey started around 2014-2015, where we you can see started the journey with the Electronic Vaccine Intelligence Network, which is the digitalization for real-time tracking of vaccine stocks as well as remote temperature monitoring till the last mile under our universal immunization program. So that journey sort of got completed by 2019, wherein we covered more than 29,000 cold chain points across the country and digitalized them. And that is when the COVID-19 pandemic stuck, and based on our expertise and experience of rolling out such large-scale public health digital intervention, we started working on ministry for digitalizing our COVID-19 vaccination drive, and then that's how the CoWIN platform came into use, and I am sure all of us have used this for our COVID-19 shots. Building on now on the learning of COVID, Government of India is now using it for our universal immunization program, and it has been named as UWIN, and recently the Honorable Prime Minister has launched the UWIN platform for rollout across the country. And then now building on this digital stack, EWIN, CoWIN and UWIN, we are also going into other areas of the different national programs in supporting the national and state governments. So the basic tenets of this digital intervention has been obviously to ensure equitable access to basic health services. Not just digitalizing the systems, but building proper SOPs and standard procedures, following which only we have done the digitalization. While developing the systems, we have ensured that we leave no one behind, that is focused on the most marginalized communities. Sustainable, open source and scalable solution. So all the digital solutions that are developed are built on an open source model so that they can be replicated both at national level in different form as well as in other countries. And also already the even platform is being replicated in many other countries across the globe. And of course, all this intervention has been led by and had strong ownership of the national and the state governments and has been implemented with them. And also, while developing them, there has been a lot of focus on for low resource settings. So, firstly, if you look at the journey of EVIN, so how EVIN came into being was, there was these three critical questions where the system tried to understand is, as a program manager at district level or block level, they would like to know that where are their vaccines for the routine immunizations. If the vaccines are available, whether they are in adequate quantity, and also, as we all know that the vaccines has to be stored in the recommended temperatures, so whether their temperature is maintained throughout. So with these basic questions, we came with the problem statement that there was lack of real-time visibility at that point of time, no visibility of storage temperature. So before EVIN came into being, it was just the stem thermometer that we had in the Iceland refrigerators and the deep freezers. So that was a challenge. Short shelf life log supply chain again was a challenge. No standard record keeping. So when we started the assessment of the UIP health facilities, we realized that there are different kinds of stock keeping practices, different kind of registers that were followed. Because there was no visibility, the infrastructure also was limited. And obviously because there was no real-time visibility, there was lack of transparency. So with this problem statement, EVIN came into being. So as I mentioned, the first step of this digital intervention was to do a pre-assessment, and this has been the hallmark of all our digital interventions that we have rolled out following EVIN. So pre-assessment means studying the existing health facilities, existing manpower, existing SOPs, as well as collecting the metadata. So as you know, in any digital platform, we have a lot of background data which is already in the system, and that's only help us to come up with actionable analytics at a later stage. So conducting the pre-assessment and collection of metadata was the first step. Then as we build on the system, the software development, we also realized that capacity building of the last mile workers, our ANMs, and now with even the ASAs, it is very critical. And we all know that whenever we go and speak to any program managers, they highlight the challenge that, the frontline workers are overburdened. I mean, they have to report in so many systems, so many apps now. So in all these interventions, what we have tried to ensure is that the data reporting at the last mile is very limited. Only actionable data is captured in the system, and also the trainings of these frontline workers are done in a more hands-on mode. So that's how we reach out to more than 1 million healthcare workers during COVID-19 time in a very short span for their for their capacity building. And then in case of EVIN, we went for the digitalization of the vaccine stock. As I mentioned earlier, now we have more than 29,000 cold chain points across the country being monitored in real-time basis. Subsequently, we have installation of temperature loggers. So these are again SIM-based remote loggers which send temperature, real temperatures of the Iceland refrigerator every 1 hour to the server. So I mean, someone sitting in Gandhinagar, the state immunization officer can observe the temperature of any cold chain point across Gujarat, and whenever there is a breach, whether it goes below 2 degree or goes above 8 degree, the concerned person receive the alert so that they can take necessary corrective action. So I think that's how the system was rolled, and then we are developing on it for monitoring and further adoption. So as I just mentioned, the metadata collection is a critical component of any digital intervention, and the same was the case of EVIN. Then visualizing the flow of immunization cold chain network in each state, so basically documenting that, and then planning out how do you digitalize the system. So this shows the system in Rajasthan. And then different forms of digitalization. So you can see that the EVIN web-based dashboard, which is more relevant for program managers at national, state, and district level, where they can get ready-made analytics of their program data. And then the mobile phone-based app, which is used by the frontline worker for entry of only some basic important data. And the temperature logger, as you can see, I think this is that is the black colored device, that is the temperature logger, which if you go, I'm sure most of you have seen already, visit a cold chain point, you will see that installed to the ice line refrigerator. So the even mobile application, which is the main device where the data entry happens at the last mile by the frontline worker, that has also evolved over the years, and which start with a basic dashboard or basic interface in the beginning, now has evolved for a more user-friendly interface for the frontline workers. And also connecting to the SDGs, how this digitalization process has contributed to the achievement of the SDGs. Of course, the primary goal is good health and well-being, contributing to the overall vaccination coverage in the country. Then obviously gender equality. So as we know, most of our frontline workers are female. So in that terms, more than 50,000 last mile healthcare workers and vaccine handlers have been empowered by this digital intervention, wherein they can provide data to their supervisors or also take action at their own end just at the click of the buttons. And then also reducing inequalities. So as previous speakers have spoken about that, although we have progress in our public health indicators, but contrast and inequities remain in the system within the country. So the system also have an equity lens wherein it makes sure that vaccine is uniformly available everywhere and no child is left behind. System strengthening for peace, justice, and strong institutions. So availability of this real-time data has contributed to strengthening of the vaccine logistics system and led to evidence-based decision-making, and of course partnership. So even a platform was initially funded by the Gavi Vaccine Alliance, but then subsequently now you'll be happy to know that it has been sustained through government funding. So I think all the state governments through the National Health Mission, they are, including Gujarat, they are sustain this event system from their domestic funding, so that the system is not hampered and it is implemented in the same effective quality manner. And also apart from the government, other partners, UN agencies and bilaterals have also collaborated for the common goals. In terms of impact of the event system, so I think many of you might know that Government of India, after the first page of event, did the techno-economic assessment of the event system, which came up with a very encouraging figure. For example, more than 75% reduction in vaccine stockouts compared to pre and post event period. Also, the return of investment was good. That is, for every $1 spent for event, there was a return of $2.9, almost $3. So these were very encouraging findings, and these were for the initial 11 states. And I think now, because after full rollout, we had the pandemic happening. So now we have a scale-up, repeat assessment being done for the whole country. And the good thing is that because the system was usable and user-friendly for the last mile, we always had more than 99% adherence. And the adherence data is very strictly monitored at national and state level by the program managers on real-time basis. So whenever there is lack of adherence, they follow up and address the issue at the grassroots level so that adherence is maintained. So now quickly talk about COVID. So as I mentioned in the beginning, the ministry and UNDP started working on this platform once the plan was made for COVID-19 vaccination. So for the first time, we had this digital acknowledgement that every vaccination is digitally acknowledged and we can trace it and verify it. The dose interval is maintained, consistent vaccine schedule were maintained, and there is a strong individual patient-wise or beneficiary-wise verification and tracking. And the same principle that we followed for EVIN, that is equitable and inclusive availability of vaccine, single source of truth, and feedback, regular feedback and analysis. Advantages for citizen, if you all remember now or recall, we had multiple modes of registration as per our convenience, simplified access to the services, as well as minimum data inputs need to be provided for getting our vaccination. So again, we ensured that because it was a huge vaccination drive, we also had a two-tier grievance redressal mechanism, which is still functional, but now Government of India is thinking of utilizing it for some other work. Of course, now COVID helpline is also used for UVIN rollout. So these are the figures I am sure all of you have seen. So using the COVID platform, we had the largest vaccination drive for COVID-19. 2.2 billion doses were administered through the COVID platform, and more than 12 ABHA IDs were also generated in the process during that period, and more than 1 billion citizens registered on even both 85% on-site and 15% online. So now, as I mentioned, now we have moved to the UVIN platform, leveraging COVID and UVIN learnings, and it is now the world's largest electronic immunization registry. As we have already discussed, the learnings of COVID has helped us to move towards UVIN. So now quickly, because I am almost done with my time, quickly talk about what has been the key learnings. So in terms of governance, there has been strong government ownership, dedicated and skilled human resource was in operations during the whole period, building standard operating procedure. As I mentioned, that in all these digital interventions, we have ensured that the SOPs and processes are standardized, and then we went for digitalization and regular training and capacity building. Similarly, for technical, we moved from traditional database to big data architecture. We ensure that there is access to security audit and compliance, a licensed product to sustainable open source solutions so that they can be replicated elsewhere. And also, we work with different other platforms so that there is data triangulation, API exchange. So this is what I was talking about. Honorable Prime Minister launched the UVIN platform nationally on 29th October. So now the last slide. So now, based on the learning of these interventions that we have talked about, now several other interventions using the digital stack has been started at national level and some at state level. So there is this TB Win, which is again a replication of COVID, which is used for the adult TB vaccination by the Central TB Division in 10 states, where they are tracking individually the vaccination of the TB patients. Then for the Animal Husbandry Ministry, they have started the replication of EVIN as AVIN, that is Animal Vaccine Information Network, that is piloted in the states of Rajasthan and Maharashtra, and the government plans to scale it up across the country from next year. For the National Rabies Control Program and the National Program for Prevention and Control of Snakebite Envenoming, we have developed an integrated platform using the EVIN and COVID digital architecture, wherein we will track both the supply chain as well as beneficiary coverage for anti-rabies vaccine, anti-rabies serum, as well as anti-snake venom. And at the state level, Government of Assam has started some unique initiative like the Swasthya Seva Utsav, which is basically a health facility assessment and ranking, which is completely digitalized, and auto-generated ranking is given. So they are having their next round of Abhiyan in the coming week. And then also they are having the Swasthya Seva Abhiyan. I'm sorry, the previous one was Utsav. The Abhiyan is the one where they do community outreach for the whole gamut of preventive and curative services under the National Health Mission, and the whole process from registration to the investigation reports as well as dispensation of medicine, the whole process for each patient is digitalized under this Abhiyan. So these are some state level initiatives, and I think this is my last slide. Thank you.
Thank you, Dr. Chaitanya. I think, in fact, we will not take a question answer as of now. In fact, we will complete all the presentation. Now I will be calling upon the our another eminent speaker, Ms. Madhvi Misra. She is Program Officer in Indian Primary Healthcare Support Initiative. She is having vast experience of more than 15 years in health system strengthening, specifically in maternal child health, and she has worked with leading organizations like PHFI, PFI, and Oxford Policy Management. She holds dual degree in the social work at Tata Institute of the Social Sciences and Public Health from the University of Warwick. And she is still pursuing her pursuing the PhD, and she has authored one important book, that is Innovation in Maternal Health and Leading Large-Scale Indian Public Health, Indian Primary Healthcare Support Initiative. And I'm happy that we are the part of the Indian Primary Healthcare Support Institute. SHSRC is the nodal agency from the health department, and we are working together. So I'm also having a privilege to work with her also. Thank you. Thank you very much.
Thank you so much, Dr. Kadri, for those kind words. My name is Madhvi, and I work with the Johns Hopkins University, Department of International Health, and we are based in Delhi. We are fortunate that we are able to work with SHSRC Gujarat. We are working with IIPH Gandhinagar, and हम लोग काम कर रहे हैं भावनगर ज़िले में, यहाँ गुजरात में. ये जो हमारा प्रोजेक्ट है वे बिल एंड मेलिंडा गेट्स फाउंडेशन द्वारा सपोर्टेड है. And I also wanted to take a moment and acknowledge our CDHO from Bhavnagar, who is here today, Dr. Chandramani. उनकी वजह से, डॉक्टर कादरी की सपोर्ट से हम लोग we are able to do a demonstration project, and I will talk in the next few minutes about that demonstration project. So जो हमारा IPSI का project है वो it's divided into 3 parts, which is measuring how your primary health care system is performing across India. The other part of our project is to demonstrate, और उसके बारे में मैं आज थोड़ी ज़्यादा चर्चा करूँगी. That is about health system strengthening. And the last part is recognize. So recognizing some exemplar work and some good work that has taken place. As Dr. Kadri also mentioned, these are our partners. So we work with NHSRC at the national level, AIIMS New Delhi. We work with IIPH Shillong, AIIMS Bhubaneswar. We work with SHSRC Gujarat, IIPH Gandhinagar, Japaigo, and that is our logo at the end. Let's talk about Demonstrate. In Demonstrate, we are working in 5 states. So we are working in Uttar Pradesh, Bihar, Meghalaya, Odisha, and Gujarat. And आज मैं थोड़ा गुजरात के संदर्भ में जो हम लोगों का प्रोजेक्ट है मेंटरिंग का, जो हेल्थ सिस्टम स्ट्रेंथनिंग का है, मैं उसके बारे में थोड़ी बात करूँगी. तो टीम मेंटरिंग का जो हम लोगों का प्रोजेक्ट है, ये अबाउट 6 से 8 महीने पहले शुरू हुआ था. What is team mentoring and why do we want to do team mentoring? Maybe many of you have heard of the CHO mentoring program, which is by CMC Vellore. Most of it was on clinical skills. What we wanted to do was we wanted to try something different. हम लोग कुछ different demonstrate करना चाह रहे थे, और उसके लिए हमको लगा कि we should try a model which strengthens the team competencies. The competency of the sub-health center team, जो हमारी health and wellness centers team है, उसको कैसे पूरी तरह strengthen किया जाए in terms of their team competencies and capacities. तो उसके लिए हम लोगों ने एक team mentoring program किया. तो ये एक cadre के लिए नहीं है, but पूरे team के लिए है. और ये जो team का जो हिस्सा है वो है हमारे community health workers, हमारे ANMs, MPHWs and ASHAs. वो सारा एक टीम बनता है सब हेल्थ सेंटर का. तो उसको लेके हम लोगों ने we wanted to make a team mentoring program for that. ये हम लोगों का एक conceptual framework है, and what we want to most importantly work on are the team competencies and processes. So जो आप लोग left side पे देख रहे हैं, left side के जो column में है, we have accountability. We have decision making and conflict. So how can the team members be accountable? How can they take better decisions together? उनके बीच में conflict resolution कैसे और अच्छे प्रकार से हो सकता है? उनकी communication, how can they effectively communicate with each other? और कुछ तय हम लोगों ने उनकी कुछ technical skills और थोड़ी सी जो essential clinical skills हैं जो बहुत बेस लेवल पे सब लोगों को आनी चाहिए एक हेल्थ सेंटर पे, उसको भी थोड़ा टारगेट करने की कोशिश की है। हम लोग यहाँ अज्यूम कर रहे हैं कि आपके जो हेल्थ सिस्टम है वहाँ पे मोस्टली लोग पोजीशन में हैं, उनको बेसिक ट्रेनिंग मिली हुई है, उनको उनके इंसेंटिव्स जो उनके इंसेंटिव्स मिलते हैं वो उनको मिल रहे हैं, और सिस्टम में सप्लाईज, ड्रग्स, इंफ्रास्ट्रक्चर वगैरह की उपलब्धि सब है। ये हम लोगों का साथी मेंटरिंग प्रोग्राम है। आई एम हैप्पी टू से कि हम लोगों अब हम अपने 4th मंथ को शुरू कर रहे हैं। 12 महीने का पायलट प्रोग्राम है, हम जो 20 फैसिलिटीज़ में कर रहे हैं उसमें से हमारे पहले 4 महीने अब हो जाएंगे दिसंबर में। उसकी हमने 2 राउंड ऑफ ट्रेनिंग्स की हैं। हमारे 20 मेंटर्स हैं, और हमारे जो मेंटर्स हैं दे कंप्राइज ऑफ Ayush medical officers from within the district health administration and nurse faculty members from the Bhavnagar Nursing College. So साथ में if you see on the right side there is an operational plan. So the mentors are 2, they work together in pairs. So we have the Ayush medical officer plus the nurse faculty, and वो साथ में एक जोड़ी होती है, वो हमारी nursing pair है, और उनको हेल्थ एंड वेलनेस सेंटर जाना होता है। इट्स अ हाइब्रिड मॉडल, इट इज़ नॉट अ वर्चुअल मॉडल। उनको महीने में 2 बार हेल्थ एंड वेलनेस सेंटर इन पर्सन जाना होता है, अपना समय हेल्थ एंड वेलनेस सेंटर टीम के साथ स्पेंड करना होता है, और उनको मॉड्यूल्स पे ट्रेन किया है जिसके अनुसार उनको मेंटरिंग करनी है। हमने एक वर्चुअल कंपोनेंट भी रखा है, दैट इज़ वाई दिस इज़ हाइब्रिड। महीने में एक बार एक वर्चुअल कंपोनेंट भी होता है जो एक एक्सपर्ट से लिया जाता है। हमने एक और नई चीज़ ट्राई करने की कोशिश की है जिसमें हमने एक व्हाट्सएप भी इंक्लूड किया है। इसको हम टेस्ट भी करेंगे देखने के लिए कि व्हाट्सएप के कम्युनिकेशंस जो थे वो किस प्रकार के हुए। हर जो मेंटर पेयर है उसके साथ उसकी जो टीम है हेल्थ एंड वेलनेस सेंटर की, उनका एक व्हाट्सएप ग्रुप बना हुआ है जिसकी हम कम्युनिकेशन भी एनालाइज करेंगे जानने के लिए कि किस प्रकार की वो कम्युनिकेशन थी और वो कैसे ओवर टाइम 12 महीने में इम्प्रूव हुई। हमारी पहली ट्रेनिंग और दूसरी ट्रेनिंग हो चुकी है, तो ये आपको स्क्रीन पे दिखाई दे रहा है। ये अभी हम भावनगर के ज़िले में कर रहे हैं। भावनगर काफ़ी लोगों को पता होगा, अर्बन रूरल दोनों है। एज ऑफ नाउ हमने अभी रूरल सेंटर्स पे ही फोकस किया है, रूरल हेल्थ एंड वेलनेस सेंटर्स पे फोकस किया है। हर 2 से 3 महीने हमारे मेंटर्स को ट्रेन किया जाता है, बिकॉज वी डोंट एक्सपेक्ट कि एक बार ट्रेनिंग में सारे मेंटर्स दे विल बी एबल टू रिटेन ऑल द इंफॉर्मेशन। हमारे जो मॉड्यूल्स हैं वो गुजराती में ट्रांसलेट हो रहे हैं। उससे पहले वो पायलट टेस्ट भी हो रहे हैं। हम कई बार उनको पायलट टेस्ट करते हैं देखने के लिए कि जो हम इंफॉर्मेशन दे रहे हैं वो रिसेप्टिव है कि नहीं। तो ये काफ़ी रिगरस एक प्रोसेस हम लोगों ने इजाद किया है। हम लोगों का एक एवेल्यूएशन प्लान भी है। ये आप देख सकते हैं स्क्रीन पे। हम लोग एवेल्यूएशन की हमने बेस लाइन की है, फिर हम एक एंड लाइन भी करेंगे, एंड इन द मिडल वी विल डू प्रोसेस असेसमेंट एज वेल। आई ऑल्सो वांटेड टू से दैट हम लोग जो हमारे जो मेंटर्स जब जाते हैं फील्ड में, उनके पास एक हैंड हेल्ड उनकी जो खुद की जो मोबाइल डिवाइस होती है उसको उसमें अपना कितना उन्होंने टाइम स्पेंड किया है। there's an online version in which you can just add आपने कब फैसिलिटी में शुरू किया, कब आपने अपना सेशन ख़त्म किया, तो उससे हमें ये भी पता चलता है कि उन्होंने कितना समय स्पेंड किया है एक एक फैसिलिटी में। तो उससे भी एक क्वालिटी कंट्रोल का मेजर रहता है। एंड आई एम हैप्पी टू से कि CDHO सर जो हैं वो उसको रूटीनली मॉनिटर करते हैं, तो उनके साइड से भी बहुत लीडरशिप है इस प्रोग्राम के लिए। एंड आई थिंक एवरीवन इज़ ईगरली वेटिंग टू सी कि ये प्रोग्राम किस तरह आगे चल रहा है। इसके अलावा भी हम लोग डेमोन्स्ट्रेशन, जो हमारी हेल्थ सिस्टम स्ट्रेंथनिंग की जब बात होती है तो डेमोन्स्ट्रेशन प्रोजेक्ट में हम लोगों ने कुछ क्रॉस लर्निंग्स भी की हैं भावनगर ज़िले के साथ, और हमारे जो बाकी 5 ज़िले हैं वहाँ पे भी। तो हमने कुछ वेबिनार्स किए हैं, हम लोगों ने एक्सपोजर विजिट्स किए हैं, और भावनगर ने एक्चुअली होस्ट किए हैं बाकी डिस्ट्रिक्ट्स को दिखाने के लिए कि उनका एनकॉस फैसिलिटी कैसे चल रहा था, उनके प्रोसेसेस कैसे हैं। और फिर हमने IPSI के प्रैक्टिस नोट्स भी निकाले हैं जब हम हर महीने निकालते हैं। सो दीज आर सम ऑफ आवर क्रॉस लर्निंग एफर्ट्स। हमने ट्रेनिंग नीड्स असेसमेंट भी की है, और हमने जो एम्स न्यू दिल्ली है उन्होंने ट्रेनिंग नीड्स असेसमेंट की थी, और उसके बाद जो ट्रेनिंग शेड्यूल था ईयर 1 ईयर 2 के लिए वो भी बनाया, और CPHC पे ओरिएंटेशन की है ज़िले की, और ज़िले की काफ़ी सारे मैनेजर्स की। और ये कुछ फ़ोटोज़ भी आपको नज़र आ रही होंगी कुछ ट्रेनिंग से जो हैं, और हमने भावनगर में 2023 में काफ़ी सारी ट्रेनिंग्स की थी। सो इसके साथ आई थिंक मेरा यहाँ पे कंपोनेंट ख़त्म होता है, बट वन थिंग विच इज़ नॉट ऑन माई स्लाइड्स एंड विच आई वांटेड टू से in respect to health system strengthening is that health system strengthening एक अकेले institution से या एक अकेले entity से नहीं हो सकती. I think it means many entities have to come together to be able to do health system strengthening. So it needs intersectoral convergence of academia, researchers, policy makers, implementers, सब लोगों का साथ में जुड़ के ही health system strengthening हो सकती है. So that is one of our biggest takeaways. So with that, thank you so much.
Thank you very much. Now I think we will be moving to the third presentation. In fact, we are having I am having the privilege to be associated with professionally with the two of the eminent speakers. I am lucky that I have the distinction of a personal association with Dr. Himansa. In fact, we are friends since UG days. He has, after MBBS, he has opted for general surgery. Later on, he has realized that he is on the wrong train, so he has completed his MPH. He has taken MPH from the London School of the Hygiene and Tropical Medicine, and then work at the Bansali Trust as a Deputy Director of Public Health, and then moved to the care and work as the Chief of the Party for Bihar Technical Support Unit, and now currently working with the as a public health expert and consultant, Bill Melinda Gates Foundation. Requesting to take his presentation, Digital Technology in Health System Strengthening.
Thank you very much, Dr. Kadri. Just slight difference with you. I haven't realized that I'm on a wrong path, but I am retailer to wholesaler, so that's why I moved from surgeon to public health. I feel honored and privileged to present in presence of my teacher, Vikas Madam, my friends Kadri, Tapasvi, Jai. I think my life has been made easier by Dr. Bhattacharya by sharing a lot of things like basic tenets of digital health systems, steps for operationalization of digital solutions, including capacity building, and emphasizing on hands-on training, benefit to citizen and system. But he has also made my life a bit more difficult because he has shown the successful model from E-win to Co-win to U-win to TB-win, Z-win, I don't know how many wins are there. What I am going to share with you, I think, is more questions, and I'm fully aware and conscious about the fact that I'm between you and lunch, and many of us might be already in a virtual lunch mode. So I'll try to be as crisp as possible, and will try to complete my presentation in time. One thing I was trying to understand, like in whether it's a tech world or any other world, who drives the technology? The answer many places is CEO, Chief Executive Officer. In many companies is a Chief Technology Officer, but then I was trying to understand to whom the CTO reports. And generally CTO reports either to CEO or CFO, which is a Chief Finance Officer. What it means that the digital transformation in any sector is usually driven from the top. We are a bit different in that sense. And in India, up to a certain extent, our good friend, a small virus, played a very important role in driving the digital revolution in the country. My presentation is divided into three components. The first one will be about the telemedicine, the second is ABDM related, and third is the innovation. All of you are aware about the e-Sanjeevani and telemedicine revolution. I'll go a bit more in detail, but as I said, I have more questions than the answer. The Ayushman Bharat Digital Mission. This policy formulation, which was pending since long, that's why I said our good friend, a small virus, helped to drive it. And on 25th March 2020, the telemedicine policy was formulated and the practical guideline was released by the Government of India. Obviously, for any such kind of solution, what is required is a hub and spoke kind of a model. But the important question is where the hub should be. The spoke is easier, where the hub should be. Should we establish hub in the PHCs and spoke as health sub-center level? Should we establish hub at the district hospital level? Should we have a centralized hub? I think the important thing which we have to learn is not by reinventing the wheel, but from the other experiences. There are so many call centers. India is known for running the call centers. What is coming out of it is very clearly a centralized approach is a more cost-efficient way. We did mistakes in Bihar. We decided that, okay, the hubs will be at the PHCs, at the district hospital. What happened? That same doctor who is responsible for routinely seeing the patient in the OPD is also responsible for taking care of telemedicine cases. Eventually, the person will neither do justice on this side, neither do on justice on this side. It depends upon the will and wish of the person, how he or she wants to utilize his time. I was looking to the skill sets and was trying to understand that if somebody is running the call center, what kind of skill sets are required. The first and the foremost is the communication, which is the most critical one. Which is again a part of the communication is equally important. And many of us must have experienced, we might have shouted number of times on the call center representative when our complaints are not heard or the response is not to our satisfaction. What becomes important is empathy and a problem solving and patience. I know as a profession, the doctor sitting here might say that, oh, these are all important part of the professional life as a doctor. But are we technically competent? And when I say technically competent means using digital technology and at the same time demonstrating all those skill sets is equally important. I don't think anyone has put the efforts to build the capacity of a medical professionals on some of those skill sets to make sure they actually take care of this as their job in the proper way. What kind of incentives are there? And I'll come to the next slides to make it more clearer. The incentives which were given was to the NMs and the GNMs, or maybe CHOs, for example, or maybe this incentive if you don't have X number of patients referred on telemedicine, you might lose something or you might gain something. Whether there were any incentives for the service provider, and here's what kind of. Right? The service provider, there were no incentives. So sometimes the incentive distort the thing, but also it creates a positive conflict. And I think here, the insight which I gathered was because of a positive conflict, which was no incentive for the service provider, particularly doctors, versus the ANMs or GNMs who were actually responsible for connecting on the telemedicine call. And I'll just demonstrate that in a minute. And I think what is important, why all we are here, whether it's a public health professional or a medical professional, is essentially ensuring that the person who is there receives the treatment or the services. If those are not met, whatever best technological solutions are in place are useless in my opinion. See the data. This is a one-day drive on 7 June 2023. We just try to see a one crude indicator from the quality perspective is time taken for individual call on telemedicine. The top and bottom are very clear, right? If I add that, it comes to almost 30. Errors are there. So essentially, if patient is spending a minute on a telemedicine call, what kind of services will be available will be a question mark. And that's why I said I have, rather than sharing more successes, more question in mind, there is a need to rethink about the quality of care. It makes life easier also. If you are interested to take second opinion, split your screen, so two doctors will appear. Moving from this to the health system digitization work which government of Bihar implemented, some of those slides which I'm going to present next was presented by my colleague, Mr. Ishmit from Param Foundation. I'm thankful to him for sharing some of those slides. I'll not go in details about all those slides, but what is important, we all know that there are so many systems. One apprehension, Dr. Bhattacharya, I have is with these multiple names brings multiple entities together, and those multiple entity, bringing those multiple entity together, it's a headache. So when we did analysis in Bihar, we found out there are more than 60 plus different kind of applications. Our web portal exists, which the government health department using it. How to bring those together became the important challenge. I'll not go in detail about this slide as I shared. Landscaping led to state visioning, and the blueprint was created for Mukhyamantri Digital Health Yojana. The government of Bihar earmarked more than 300 crore rupees for this. The agency was selected, various partners combined with the government initiated this one. And there are successes, but I think the more than a success is what I am interested to share is this. Any digital transformation is important, depends upon the change management. And my first point, CEO, CTO, was linked with that. In Bihar, we were able to demonstrate and see the success because it was driven by the Additional Chief Secretary, Health Department, this entire initiative, and that's why the on-the-ground results were visible. But I'll come back to this point again in the next few minutes. The second important thing is from the change management point of view, which my friend already highlighted, is the capacity building, and what is required is essentially digital training, digital literacy, which might not be in the conventional way we train the people. It's not a one-time effort, it's an ongoing effort, which is very, very critical one. All of you must be aware about GIGO, garbage in, garbage out. I was trying to understand why this GIGO take place and how best we can prevent this GIGO. I think the important thing from the GIGO point of view is the first fundamental question, for whom we are collecting data. All the system we build in this country, we build the system for the higher up. We want to send data up. We never build a system for the person who is going to utilize and going to punch the data. If we really make sure that the system is built in a way where the person who is using it is essentially going to benefit, you don't have to run behind the person to use the solutions, and you don't have to run behind the person to make sure that the right data is punched into system. I think the next question is, who benefits? As I said, if the person who is responsible for punching data get benefited, everyone up in the system will get benefited. Because there will be no garbage in and there will be no garbage out. The third reason, in my opinion, is we build multiple systems, we don't integrate them. यहाँ पे भी पंच कर लीजिए, यहाँ पे भी पंच कर लीजिए, यहाँ एक नाम लिख दिया, वहाँ दूसरा नाम लिख लिया, कभी मैच ही नहीं होगा. We say we want to transform ourselves and want to become digital, but we still continue with the paperwork. So these are like the programmatic aspects. Then the system aspects. Simple, whether we are giving a drop down to standardize the data dictionary. When I was doing analysis, I've seen male pregnant. I remembered Arnold Schwarzenegger, who became pregnant. I think what is important is when you put the rules and conditionality should be built in the system in such a way that this kind of error can't be allowed. The solutions, as I shared problems, solutions lies into it. I think the one fundamental thing which I feel important is somewhere we are missing that healing hand. फील्ड में जाके जब देखता हूँ तो डॉक्टर कंप्यूटर पे एंट्री कर रहा है, उसका ध्यान पेशेंट की तरफ होता ही नहीं है। एंड आई थिंक समवेयर पेशेंट आल्सो मिस दैट।
Dr. Hemant, 2 minutes, sir.
2 minutes, yeah. I think what is important is, on one side, there is a fear of misuse of data, right? We have seen the decline in OPD in some places because people felt that by doing this QR card or giving Aadhaar, actually our data will be shared outside and will create problem. But at the same time, we also are aware about the security threats which AIMS face, and similarly, it exists for each one of us. I just tried to understand what happened with the AIMS. New system was installed into the new buildings, but people forget there is old building and old system and forget to maintain those systems. And obviously, many times what we do, अरे मुझे उतना time नहीं है, मेरा password मैं किसी को दे दूँगा. That's a very common thing which we are doing it. And then that creates the security breach. So I think what is important is, when we are fighting with our friends coronavirus, are we really prepared to fight with the other virus which are important from the digital threat point of view? Quickly moving from the last part of my presentation on the innovations, I might overshoot a 1 minute, Dr. Kadri, is about innovations. We try to understand about the use of the smart scope for the human papilloma virus, how it can help to detect the cervical cancer early. The results were not what we were expecting. I don't want to go in details about results, but I was trying to understand why the results are not as per expectations. And I'll go to the last, which is a future, which is everything algorithmic, which looks beautiful. But I think important is on which data we are building algorithms. Whether it's representing the entire population, it's based on the Western countries. Ma'am is here. When I learned, what I learned is the Indian standard for malnutrition are different than the Western standards. So I think we have to keep in mind that if you have a garbage in a garbage out kind of things, even if your AI or machine learning, if you are going to use, is not going to work. The accountability with whom? If something goes wrong, who will be responsible for it? Are we prepared to bring policy change with the speed the technology is building, right? Ultrasonography, now you actually don't need the sonologist's presence. What you need is a nurse to whom you can just train how to move the probe from one side to other side, and the machine will do, AI and machine learning will do, remotely radiologists or sonologists can see. But does our PCPNDT Act allows that? Task shifting is a major benefit to us. I think ethics and equity. We don't have to forget all technology which comes will come with its price, and the which are meant for the poorest of poor will benefit the richest of the first. If I ask experts, will be a very small percentage. But in my opinion, what is important is interoperability, the infrastructure hardware requirement, standards, data exchange, user interface, access to data, automation, internet access, funding, legislation, evidence, and digital skills are the important ones. Thank you very much.
So I think Hemant was kind enough, but I was not kind enough. So still, I am a villain standing between you and the lunch. I thought about when we are talking about health system strengthening, and we are talking about the participants who are delegates here are learning about the national and international thing, but definitely they should be, I humbly believe that they should be also aware about what efforts at the local level also happening. And that's why, in fact, I requested Dr. Deepak Saxena, and he has kindly agreed to allow me 5 or 7 minutes for presenting what are different initiatives taken by the Gujarat state in the health system strengthening. So I will become the bullet train, so pardon me. In fact,
this presentation will be in the two parts. I will be saying that Gujarat state has got two things. One is the institutional mechanism about the health system strengthening, and another is the one specific project for the health system strengthening it has taken up. So it's regarding institutional strengthening, I am saying that it has created for last 5 years State Health System Resource Center. You must all aware about it. What is the State Health System Resource Center? The main vision is its vision is and mission is the effective and efficient health system by providing technical support to that. And our core areas is the policy planning, and this health system strengthening, in the health system strengthening, research studies, evaluation and health programs, then best practices, innovations and documentation, data mining, evidence generation. And through this, in fact, SHRC is now through 3 divisions working. One is the policy planning division, knowledge management division, and the state, which includes the health system research and the state innovation hub, and definitely analytics is the part of that. Besides that, in fact, we are also having the 3rd division, which is the state public health administrations division. So this is the institutional mechanism, and we have been involved in the giving advices and recommendations for the various activities which is targeting with the health system strengthening. Another initiative is that we have taken up, state has taken up the one project with the support of the World Bank, which is World Bank assisted project. I will be saying it is of around $500 million, or you can say $4,000 million for the 5 years, and the implementing agency is the Commissioner of Health, and SHSRC is the nodal agency. And I'm happy to share that in the designing of this health system strengthening project, 4 IAPSM members were part of this entire project. So that is how you can contribute to the health system strengthening, besides also talking on the platform. So it has got 4 result areas, that's CPSC, adolescents health, disease surveillance, and the quality of care. I will be coming to the specific initiative, won't be going into the specific principle what we have taken when we have designed this project. What we have thought about that we'll be picking up the areas in the health system which are not taken up by routine health system activities or the programs and service delivery mechanisms, and also in fact newer emerging areas which are we require to take up. And based on that, in the CPSC we have taken up CPSC. In the CPSC we have taken up the NCD, mental health and geriatrics, and how we can strengthen the monitoring of the CPSC. This is the area. Another is in adolescents girls we were talking about the anemia. Then other HNLE, that is how other stakeholders can be included into that, and how we can empower it. Later on I will be talking about that thing. And the 3rd result area was the disease surveillance, where we are using a digital platform in a big way, and we'll be talking later on also. And along with that, in fact, AMR and the One Health we have taken up. Then quality of the care we have thought about as a part of the quality care. In fact, we have moved beyond the certification, and various activities we have planned as a part of the quality of care. This is the main slide I will be saying that we'll be sharing and talking about. This is the few initiative on the Shrestha Gujarat and SHRC. And as a part of this health system strengthening, I will be saying the top row we will be talking about, we have focused on we'll be saying that which is about the governance or the management side. Last two are mainly cross-cutting, rest of the areas are the health problem areas. That way how we are focusing on and working on the strengthening the health system in not 1 or 2 area, but comprehensively key areas of the health of priority of the state health. In the strengthening governance and leadership, in fact, we are investing in the building the capacity, and we are carrying out the healthcare leadership types of the works. IIPG, one of them, IIM, we have worked with the IIM. So far more than 200
All check, 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 all sound check, all check, check. 1, 2, 3, 4, 5, 6. Check, check, all check, all sound check, all sound check, all sound check.